talk about neuroscience is one of the most important components of science which covers structure and functioning of the whole nervous system. The OIC region is vast and diverse, comprising of many developing and underdeveloped countries, with still in need of skill and knowledge in scientific research for healthcare sector. This conference was supposed to be held in Islamabad physically. Due to the pandemic breakout, we have to convert it into a virtual mode. We have speakers from Turkey, Malaysia, Iran, Egypt, Afghanistan, Albania, Saudi Arabia, Indonesia, UAE, and Azerbaijan. We have over 150 participants online attending this conference. So we will formally start off this conference with the recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الرحمن علم القرآن خلق الإنسان علمه البيان. الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان. صدق الله العظيم.
Jazakallah. Now I will request Professor Dr. Muhammad Wase. He is a section working in section of neurology, Department of Medicine at Aga Khan University, for his introductory remarks. Professor Wase.
Assalamu alaikum, Bismillahir Rahmanir Rahim. First of all, I would like to welcome you all for this first OIC International Conference. And this has been a great start. I am really thankful to Professor Dr. Iqbal Chaudhry for his vision and guidance. And this is an important part of the scope of the comstech. And this OIC, I think, is a very important part of the world. It's like about 1.9 billion population out of 7 billion, which is more than 25%. And there are 57 countries. And we have a number of middle-income countries, low-income countries, and high-income countries. But neurological issues related to this part of the world are extremely important and probably contribute about 10% of the healthcare problems in the OIC area. It's very important that we learn and we train and we improve care of neurological disorders throughout this part of the world. And this comstech and OIC platform could be a great help in improving care related to neurological diseases in this part of the world. And this part of the world is suffering from a huge burden of stroke and epilepsy, migraine, and other neurological disorders. A lot of training is needed, a lot of education is needed, a lot of improvement in care is required, especially in middle income and low income African countries and some of the Asian countries. So this is a great task, and I'm really glad and that OIC countries' neurological societies have agreed upon that we will all work together to improve neurological care in OIC countries. And this OIC conference is basically a start of that activity. So we have more than 20 countries from the OIC region who are participating at this conference. And this is just an introductory conference. We wanted to share the neurological issues and challenges related to Asia and Africa and to these countries. So we have a dedicated session on neurological training, awareness, advocacy, education, and training in Africa, which is from tomorrow. And today we'll be learning about neurological issues and challenges in Asian countries and some of the African countries. So this is a great start, and we hope that this will translate into more meaningful and structured program where we are thinking that we should be able to establish a OIC Neurology Academy under comstech, and that should be working in to promote neurological training and education in this part of the world. We are working to establish a neuroscience directory of OIC countries, where we are going to include all the neurologists, psychiatrists, neurosurgeons, neuroradiologists, and neuroscientists. So that's going to be a huge database of all the neurosciences throughout OIC countries, and this has not been done. I think that would be a very important resource for future. So this is a good start, and hopefully this will translate into more academic activities and more involvement of the neurology community and neuroscience community throughout the world. There are thousands of neuroscience persons who are basically belong to these OIC countries, and they live in US, Canada, Europe, Australia. Hopefully we will be able to make a system so that they could also contribute to this OIC world, and that would also translate into more collaboration for research and training and education. I would like to thank again Dr. Iqbal Chaudhry for allowing us to work under the platform of comstech for this OIC and neurology initiative. And I'm especially thankful to Hasib and Haris at comstech. They have done a great job and wonderful job. And I'm also thankful to some of my team members. Safa Yunus is a medical student in US. She has been working with me for quite some time related to a database of OIC neurology societies, and Dr. Parvez Nayani, who is also working on a Central Asia initiative related to OIC neurology. So I'm thankful to all of them, and hope that this platform and this event translates into meaningful actions and meaningful training and meaningful education and programs. So again, thank you again, and hopefully you will be able to enjoy the whole session. If you are unable to watch one or two part of the session, all the videos will be available on YouTube, so you could watch, and you could also connect to the speakers and to us if you want to contribute in future. So again, thank you very much, and hope to see you throughout this conference, and hope to even connect with you after the conference. Thank you again.
Thank you, Professor Wasil. Now I will request Coordinator General Comstech, His Excellency Professor Dr. Muhammad Iqbal Chaudhry, for his welcome address.
Professor Dr. Muhammad Wasi, Professor Dr. Abdul Rashid, my colleague Hasib and Haris, and distinguished participants, Assalamu alaikum wa rahmatullahi wa barakatuh. You see, as mentioned by Dr. Muhammad Wasi, the importance of neuroscience is now globally recognized. He is a scholar par excellence. He has contributed not only in training of individuals in the field of neuroscience, especially clinical aspect of it, but also has contributed in raising awareness about neurological problems and the importance of research in this field. So we're very, very fortunate to have Dr. Wasi on board. He is spiritually motivated. He's one of those individuals who wish to serve, and canvas of his services is beyond Pakistan, and therefore OIC and comstech is very fortunate to have him leading this whole effort of neuroscience promotion of capacity building, institutional linkages, and as he has mentioned, many of these initiatives which we intend to take in near future. this workshop is a curtain raiser, though he has been delivering lectures on the platform of Comstech even earlier also. But this workshop is certainly an extremely important one, this conference, because we have participation from many, many countries, and I'm sure they are all in their own merit leading scholars in this field who covers whole range of different topics. They are clinicians, they are doctors, they are neuroscientists, they are professionals working with the government and with society, all targeted to raise awareness about the field of neuroscience and its implications in human life. Comstech, as has been mentioned, is a very large organization. It is a steering committee, ministerial standing committee, which in OIC system has a very special meaning and significance. Steering committees have special stature in OIC institutions because they are chaired by the president of host country. So Comstech is chaired by the president of Pakistan and co-chaired by the prime minister of Pakistan. It is headquartered in Islamabad. Me and my colleagues are in Islamabad, and Professor Vase is in Karachi, where we were hoping to have this event in person, but inshallah, hopefully soon when situation will improve, we will resume activities with full quorum, inshallah. Comstech is primarily meant to use science and technology as vehicle for development. And we all understand that science and technology is the driver of change. Today, what we see the development is primarily meant, and the edifice is laid in science and technology. So without science and technology, no country can even imagine of moving forward in any aspect of life, whether socio-economic or cultural, because it is all embedded in human behavior. Comstech has initiated large number of programs. I would like to invite you to kindly visit Comstech website. It's a very happening place. You will find lots of activities of different kinds. We are working on capacity building through a very large number of fellowship programs, technician training, research scholars. We are working in developing awareness about the newly developed technologies within the OIC world, and health is certainly one very important aspect, and you would find those details in technology portal. You will find many of these consortium of excellence institutions, which are some of the finest institutions within the OIC countries and are available for collaboration and mobility. So there are many programs targeted to build capacity, both in terms of institution and individual. And neuroscience is certainly very important one. I don't want to pretend that I know neuroscience very much, but I have looked into statistics, and it was really very surprising that despite the fact that the share of publications in science and technology of the OIC world has increased substantially in last 10 years, our contribution in the field of neuroscience has been very low. The last statistics available says that OIC collectively, all 57 countries have published 467 papers, only 467 papers in during 2011 to 2015. And out of 27 disciplines which were mapped for publication and citation, neuroscience was only 21. So as Dr. Wasi mentioned, there are very large number of neuroscientists originated from the Muslim world working in top institutions of the world. There are only a few who are active in OIC countries, and largely the reason has been that they are not able to get conducive environment or right institutional backup, which is needed for them to perform. And that is what we intend to do through various initiatives, as been mentioned, that our focus would be to somehow link them together into a network of scientists in neuroscience, clinicians in neuroscience, and virtual network of institutions working in the field of neuroscience. He mentioned about the network of academies of neuroscientists. This is an extremely important initiative and he's very actively engaged in it. One important activity which he hasn't really mentioned is our plan to conduct training workshops in the field of neurocritical care, stroke management, and other aspects of neuroscience in terms of clinical practices. And AIR 2022, we're primarily planning to have at least 2 of such workshops for the training of doctors in Africa. And this has been discussed with Excellency, the Secretary General of OIC, and he has been very pleased to learn that such an important part of healthcare is now on top of the agenda of comstech. And he has particularly thanked all those individuals who are contributing, and Professor Vase certainly has a leadership role in this very important field. Without much of delay, I would like to welcome you on behalf of all of my team and individuals who are contributing in this conference. And I sincerely hope that you will be able to benefit from the excellent presentation. Would be available for you as a permanent record on comstech YouTube channel, and your feedback would be very, very important, because this would actually help us to tailor these activities according to your need. With this, I would like to thank you all for your participation and wish you best of luck. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, sir, for talking about different initiatives and programs of comstech. Now we will move on towards the technical sessions. This conference would prolong for 2 days. We will have 2 sessions today and next 2 for tomorrow. We have excellent resource persons from different countries of OIC. They would be talking about the burden and challenges of neurological care. They would be talking about stroke care, stroke management, and improving stroke care in OIC countries and specifically Africa. Now we will move on towards the technical session 1. I will request Professor Vase to introduce the chair for this session 1. Dr. Vase.
Chair and co-chair for the session 1, Professor Dr. Hamidun Basri is well known across the globe. He is the president of the Asian Oceanian Association of Neurology, and he has also very close link to Pakistan. Many years ago, he has visited to Pakistan, very active in training and very active in neurological care promotion. He is based in Kuala Lumpur, and we hope sometimes to see him here in Pakistan. So he is the chair of this first session, and co-chair for this session is Professor Dr. Salim Badich. Salim Badich is the president of Pakistan Society of Neurology. He's head of neurology at Bolan University of Health Sciences in Quetta. So these two are the leaders of the neurology in Asia and Pakistan. They are going to chair and co-chair this session. So it's a great honor and pleasure to have him on board and to be here with us. And Dr. Hamidun is going to deliver a lecture also today. So I'm again thankful to our chair and co-chair for being part of this this very important initiative. And we like to have your comments, I think, at the end of the session too.
Thank you, Professor Wasai. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh. I would like to thank the organizers, Comtech, also Professor Wasai, for inviting me to chair the first session. I have with me my co-chair, Dr. Salim. I hope he can help me too. It's about to start Zuhur here, so the call of prayer will soon come because I'm near the mosque, so it will be very loud. So if that happens, I hope Dr. Salim will help me. So thank you so much for the invitation, and I think this is a great opportunity for us in the OIC region, in the Islamic countries, to actually come together. And hopefully we will be able to bring our minds and our brains together to come up with some form of organization or institution that can improve neurology forward. And Professor Wasai has been instrumental. He's a friend and a colleague for a long time. And I would salute his vision and wisdom to organize this first YC Neuroscience Conference. So the first session would be on the neurological challenges or burden in many parts of the OIC region. There are 5 speakers, which will be from Afghanistan, from Iran, from Pakistan, from Wasai himself, and myself from Malaysia, and from Turkey. So without further ado, I would like to invite our first speaker, which is Dr. Habibur Rahman Habib, who is a consultant neurologist at the FMIC hospital in Kabul, Afghanistan. I visited Kabul in 2003, many years ago, for some relief work, and but it's a long time ago. So I would like to know too, what is the current burden and challenges of neurological care in Afghanistan? Dr. Habibur Rahman. I think it will be pre-recorded. So.
Assalamu alaikum. Bismillahirrahmanirrahim.
Wa alaikum salam. Are you doing this live, Dr. Habib?
Yes, Dr.
Okay. Please, the floor is yours.
Flash and report. Flash of hand.
Can you see your screen?
I have a little technical problem in sharing the slides. As the screen to be
Habib, you could send your presentation to Haris. You could share from.
Okay. It's okay. I got it.
Okay.
Yes, now it's visible to us.
Sorry for the delay. Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for inviting me. I'm very happy to be there presenting and giving you a picture of what is going here in this part of the world. As you all aware, Afghanistan is one of the countries that making the breaking news over more than 4 decades. And unfortunately, all breaking news from Afghanistan is from war, killing, destruction, and all these things. So from such country, from such background, I'm presenting and giving you a picture of what is going here regarding neurological care and neurology practice. As you know that Afghanistan is a landlocked country struggling for more than 4 decades of conflict, displacement, destruction of infrastructures. Political instability that we have in Afghanistan, it has affected all aspects of life, including the health system in Afghanistan. Lack of resources, lack of education. These are the main challenges and the main problems that we have in Afghanistan. Afghanistan is a 40 million population with 3 million of refugees. They are living inside Afghanistan, and also some of them are living outside Afghanistan. And when we say the refugees, you know that what the meaning of refugees, especially in this third world means. The refugees mainly in Afghanistan, they are struggling to find their food and water. So the neurology or the health system for refugees are completely, as I can't say that it is unavailable. I can't say that it is poor. It is less than poor. Afghanistan has a predominantly young population, with 50% is less than 18 years age, and 77% of Afghan populations are living in a rural area. Rural areas in Afghanistan, mostly they are disconnected, the roads are unpaved. The health services in many areas in provinces and also in those areas with more than 20,000 populations, even we don't have even a nurses there or general physicians. Regarding the neurology training in Afghanistan, Afghanistan has no pure neurology training program. Till now, we don't have any official neurological training program in Afghanistan. What we have, what is called neuropsychiatric residency, in which way it is designed that residents are getting a 3 years residency, getting training both in psychiatry and also neurology. And we have only one neuropsychiatry residency program. And even in that program, residents are training for 1 year or 1.5 years in neurology. The resources are lacking. They don't have neurophysiology lab. They don't have radiology facilities. And the investigatory lab and all these things are lacking with this residency program. For the first time in past recent years, through an initiative that kindly Dr. Muhammad Wasi facilitated it, in 2011, first Afghan physician joined the Aga Khan University, and he got training in pure neurology training for 3 years. After returning, he established an OPD practice here in FMIC. And then through the same way, I joined the Aga Khan University in Karachi. And I was graduated in 2019. And then later on, I joined FMIC. We are the only 2 neurologists here in Afghanistan of 40 million populations. As it is, I think this is something happening in third world. Most neurology patients are treated by general physicians, by neurologists, and sometimes even by non-medical persons. The distribution of physicians and also specialists in Afghanistan, due to security reasons and also due to some financial reasons, most of specialists, most of general physicians that we have, they are based in big cities. For example, in neurology, I mentioned that we have only 2 neurologists. In gynecology, I can give an example that we have more than 350 gynecologists. 70% of them are located based in Kabul, and the remaining are located in centers of the cities. And there are some provinces that we don't have even one specialist. As I mentioned earlier, that currently only 2 neurologists are available in Afghanistan, I and Dr. Ismatullah. There is no pediatric neurologist in Afghanistan, and all pediatric neurological issues are addressed, as I mentioned before, by general physicians or non-neurologists. And also we at FMIC, also we are seeing the pediatric neurological patients. But fortunately, here at FMIC, we have the first and only neurophysiology lab in the country. We have the facility of EEG, and also we have the facility of doing EMG here. But for whole country, it is very less, especially the burden of injuries, the burden of war injuries, and all accidents and nerve injuries, and all these things are very much here in Afghanistan, but we have only one EMG or neurophysiology center for whole country. Beside that, we have good radiology unit, we have good quality MRI and also CT scan here at FMIC. But again, like neurophysiology lab, it is not enough for whole country. And the good quality radiologists to report the imaging is still there is a challenge in Afghanistan. Neuroradiologists we don't have. They are general radiologists that they are reporting the MRI and CT scan. There are some other cities out of Kabul. They have some CT imaging, which is very poor quality and reported mostly by those who are not well trained in radiology. Laboratory investigations are another big challenges in Afghanistan, especially neurology field. I can give you an example that for example, we can't do autoimmune workup here for our patients. We don't have oligoclonal band in provinces. Even they don't do CSF analysis. The majority of Afghans are living in rural area. No one is able to do a CSF analysis, and most of patients' CNS infections are empirically treated. When they are treating a patient with possible viral or bacterial meningitis, and then after 2 or 3 weeks that he is not responding to medication, they are going to put the patient on anti-tuberculosis for 1 or 2 years. Availability, quality, and cost of medication is another issue in Afghanistan. Nearly all medications here in Afghanistan is imported from neighboring country. The quality of medication is a big issue. The cost is another issue, and most of time they are not available. For example, IVIG, most of the time we are not able to give IVIG for our GBS patients or any other patients needed IVIG, and it is very, very expensive. For those who have less than $100 per month income, IVIG cost is around more than $3,000, which is very expensive. And another very simple medications are not available. For example, I have many myasthenia patients, they are struggling to find Amigra in anti-epileptic medications. These are all challenges that we are facing here in Afghanistan, especially for epilepsy patients who needs to have anti-epileptic for 2 or 3 years. Most of the time the treatment is interrupted and they cannot afford the medications, and the medications are the one which is available, it is available only in big cities, in Kabul, in provinces, in rural area. They cannot find the medication. If they find the medication, they cannot purchase it. And they are not able to come to big cities for their medications. Besides that issues that I mentioned here, there are some social issues which are aggravating the existing problems and burden of neurological disease in Afghanistan. For example, lack of awareness, illiteracy in seeking treatment, delay in seeking treatment. Many times we are having epilepsy patients, rarely they are coming in their first day or first week of first attack. They are coming from rural area with history of years of untreated epilepsy. And poor complaints is another issue. Of course, this is something expected. Inherited disorders are very common due to consanguineous marriage here in Afghanistan and some other cultural related issues. Misconceptions, another big problem that we have here in Afghanistan, misconceptions regarding the difference between psychiatric and also neurological issues. You see many psychiatric patients, they are coming to us in neurology clinic, and many neurology patients are going to psychiatrists, and I have seen even surgeons, neurosurgeons, and even non-neurosurgeons, they are seeing psychiatric patients and also neurology patients in their clinic. Even the general physicians that we have, due to poor training during faculty and also during their residency, the specialists that we have, internal medicine specialists and also the pediatricians, their knowledge of neurological disease is not a satisfying level. Mistreatment and misdiagnosis are very common practice here in Afghanistan. Regarding the real burden of neurological issues here in neurological disease here in Afghanistan, unfortunately, there is extreme lack of data regarding the neurological disease in Afghanistan. But since the country is well known for infectious diseases and also inherited diseases, and the burden of hypertension and diabetes is very high and also in this country. So, and also poor economic, socio-economic status, malnutrition, poor maternal and newborn care services. Afghanistan has one of the highest maternal and also newborn mortality rates in the world. Close relative marriage, this is a common thing happening due to cultural issues here in Afghanistan. An expanding population of drug users, this is another risk for burden, increasing burden of neurological disease here in Afghanistan. These are all factors that are indicates that burden of neurological disease in Afghanistan is one of the highest burden in the world. Life expectancy is a little bit increasing in Afghanistan. It is up to 60 years, which is bolstering or increasing the cerebrovascular accidents and also those neurological issues related to hypertension and also diabetes. So based on all these indicators and risk factors that I mentioned, and based on what we are seeing here in our clinic in FMIC is a referral clinic we are seeing mostly those challenging neurological cases or those refractory epilepsies that are not well respondent in another hospital. They are referring to us. Our data is not that much reflecting the real picture, what is going in society. But again, neuroinfection is among the commonest presentation in all age groups, while birth asphyxia, inherited related neurodevelopmental disorders, and also epilepsies are very common in pediatric population, while in adult population, cerebrovascular accidents and also CNS tumors are very common. In another issues, again, after emergence of COVID-19, the increasing number of immune-mediated disorders, which I mentioned earlier. Unfortunately, we are not able to do any blood-related workup for these disorders. We are only doing imaging, and based on that, the only available medication that we are using most of the time is pulse therapy, methylprednisolone. Beyond that, other therapy is not available. At the end, I want to mention again that security remains the big challenges here in Afghanistan. In past 2 decades, 20 years, most Afghans, especially the physicians, are living in war state, in continuous and chronic state of fears. Physicians are among those population that are mostly targeted by kidnappers, I have experienced, we have seen many physicians kidnapped in past 2 decades. Even in past few months, we had few physicians or doctors who are working in neurology field, 2 neurosurgeons and also 1 psychiatrist. They were kidnapped. 2 of them were fortunately released. 1 was killed and another is still, we don't know about him. So this is the situation that we are practicing here in Afghanistan. Security is remaining the big challenges in Afghanistan, and another thing that making the situation worse, that those who get experience, get knowledge or certificates from another countries and also here in Afghanistan, most of them are leaving the country with any opportunity they want to go outside and practice outside, which is making the situation worse. We have many universities, professors and teachers left the country. So this is I try to put you in picture of what is going in Afghanistan. And thank you for hearing and have a good day.
Thank you, Dr. Habib, for the.
Can I ask a few questions to Dr. Habibur Rahman?
Sure, Professor.
Yes.
Dr. Habib, I have 3 questions. Number 1, what is the stroke care in Afghanistan in terms of like acute stroke care, stroke unit or TPA available or rehabilitation services? Number 2, do you plan to start any neurology training program in Afghanistan to train neurologists in Afghanistan? And number 3, do you have any system to train like the general doctors related to neurological care? So these are the 3 questions, and 1 comment that from Pakistan, and Dr. Shahriar Nafisi is also here. We are your neighbors. If you need any help in terms of neurological training and education in Afghanistan from Pakistan or Iran or one of your neighboring countries, I think please let us know. We could help and we could arrange sessions and those kind of things. So this is just a comment, but please respond to my questions.
Thank you for question. The stroke unit is not available here in Afghanistan. Even at FMIC, we don't have stroke units, and we have TPA. We don't have TPA, and acute stroke care usually it is in terms of TPA, and these things are not available, unfortunately, here in Afghanistan. Regarding your second question, yes, we are planning here in FMIC to start the neurology training program, but still there is funding issues. We are trying to find fund for residents and for this program. We fortunately, as the steps toward training, toward establishing a neurology training program in Afghanistan last year, we started inpatients. Our practice in FMIC was OPD practice. And for 1 year, we have inpatient services also started here at FMIC. Regarding the training other physicians, giving them neurology training, we have some CMEs in other hospitals inside Afghanistan. Again, due to security, we are not able to go to outside capital, outside Kabul, to other provinces. And there are some visiting physicians, other hospitals sending to us. We are training here at the FMIC.
Okay, there's 1 question from the floor here, Dr. Habib. What are the common neurological conditions and their management in Afghanistan? You mentioned, I think, some of them. Probably you can mention the most common that you see in your practice.
The most common is the most common in all populations, neuroinfection related, and also epilepsy is one of complications of neuroinfection diseases. Epilepsy remains the main presentations. Of course, that headache is a common presentation of patients at our OPDs, but the epilepsy remains one of them. What I say that we have challenge in making diagnosis and availability of medications and follow-up of the patients here in Afghanistan. And after that, a stroke, cerebrovascular accidents is very common. The patients who are coming to us, usually they are coming late and they are mismanaged, and even they don't, after weeks of strokes, they are coming to our facility without any imaging.
Yeah, it's probably a big challenge for you to practice there. Only the two of you in the whole of Afghanistan, so huge challenge there. What about the COVID infection? Has that affected in any way your practice, Dr. Habib?
I mentioned before that the immune mediated diseases burden has increased after COVID infections. We are seeing a lot of immune related neurological diseases. We are seeing increasing number of young population with cerebrovascular diseases, CVCs, stroke. Young stroke workup, it is not available here in Afghanistan. We are just doing the ordinary workup for young patients, like lipid, sugar, and all these things. Echo and these things are available. Beyond that, we don't do any further workup for young stroke. The burden of young stroke and also immune mediated has been increased after COVID-19.
Probably one last question from the floor here, from Javiria Arif. Is government of Afghanistan taking any action against close relative marriages to avoid inherited neurological disease?
Not yet. No, they have many other priorities right now.
Yeah, I understand that. Okay, so I think we thank Dr. Habib for your presentation and the Q&A. Dr. Nafisi, Professor Nafisi is prepared for the next talk. Is my co-chair around to introduce Professor Nafisi? Dr. Salim?
I think Dr. Hamidun, that you can introduce him. I think
Okay.
Dr. is not joined. There is one
here?
more question,
Okay.
if you would like, we can take. This is just
Yeah.
last question. Yeah,
Yeah.
by Dr. Muhammad Ilyas.
Sure. So the second speaker is Professor Shahriar Nafisi. He's a professor of neurology and the neurologist in chief at the Shariati Hospital, Tehran University of Medical Sciences, and the editor-in-chief of the current Journal of Neurology and vice president of the Iranian Neurological Association. And his talk is on the burden and challenges of neurological care in Iran. Professor Nafisi. Hi.
Thank you. Hello, everyone. Thank you, Mr. Chairman, for the kind introduction. I would like to thank Professor Vasai for inviting me to this meeting, and also to Comstech and Professor Chodari for this invitation. I'm going to talk a little bit about the burden of neurological care in Iran, the situation of neurology teaching and training in Iran, and also the challenges that we are confronting with. So I think you can see my slides. So I'll pass this. So as you already know, neurological disorders are the main cause of disability in the world and the second leading cause of death. And I think this is all over the world. All the countries have probably the same prevalence of and the same burden of neurological disorders globally. And our four largest contributors to neurological disability are stroke, headaches, Alzheimer's disease, and meningitis. But this is somehow different in other countries, and I'll tell you about Iran. So Iran is a country with 1,600,000 square kilometers area and a population of 84 million. It ranks 7 in the OIC region, and it spends about 3.6% of the GDP on education and 8% on health expenditure. So modern neurology training in Iran has a history of about 50 years. Before that, neurologists were trained abroad in France, US, UK, and other countries. But since then, many training centers have started training neurology residents in Iran. And now we have nearly 15 centers that are training neurologists, and nearly 80 neurologists are graduated each year. Now we have more than 1,400 registered neurologists and 215 pediatric neurologists practicing in major cities. And this is the map of Iran. The green dots are the primary and the major centers of neurology training located in Tehran, Isfahan, Tabriz, Mashhad, Shiraz, Kerman, and there are some other minor or secondary centers that are now training neurology residents. We also have several fellowship programs, one for MS, 4 centers for stroke and neurovascular intervention, and also 3 centers for epilepsy, 2 centers for neuromuscular medicine and sleep medicine, pediatric neurology, 1 center recently for headache, 2 centers for neuropsychiatry and behavioral neurology, and 2 centers from this year trained fellowships in movement disorders. There are 3 professional organizations in neurology. The main one is Iranian Neurological Association. We also have Iranian Stroke Society and Iranian Child Neurology Society. I just briefly introduced Iranian Neurological Association. It was founded as Iranian Society of Neuroscience in 1993 by Professor Brimani, and the name was changed to Iranian Neurological Association in 2003. It's the only major organization representing adult neurologists in Iran, and the board members are elected every 3 years. The current executive committee, you see the photos. The current president is Professor Hossein Paktaman. And we have several patient support groups like National MS Society, Iranian Epilepsy Association, Iran Dementia and Alzheimer Association, Neuromuscular Iran, Iranian SMA Association, and Rare Disease Foundation of Iran. Major national neurology events happen each year in Iran. The main one is the National Neurology Congress, which is held for 4 days each year. This year it was in August. It was completely virtual, and it had more than 1,200 participants. And we also have other major neurology meetings like MS, epilepsy, stroke, child neurology, headache, neuromuscular, movement and cognitive disorders. These are held each year or every 2 years. And we have some scientific publications and journals in the field of neurology and neuroscience. The first one is Current Journal of Neurology. It was previously named Iranian Journal of Neurology. The name has changed in the past 2 years. It has been published since 2002. and we have Iranian Journal of Child Neurology, Archives of Neuroscience, Basic and Clinical Neuroscience, and Caspian Journal of Neurological Sciences. So a few words about the burden of neurological disease in Iran. This first slide shows the main causes of death and disability in Iran. This is from the
GBD.
Yes, GBD 2019 study. As you see, the main cause is the ischemic heart disease, then road injuries, stroke, neonatal disorders, and so on. There has been some changes from 2009 to 2019. As you see, there is significant decrease in road injuries. There is significant drop in neonatal disorders because of availability of NICUs all over the country, and a significant decrease in congenital defects because of maternal screening and prenatal diagnosis. But other diseases have grown significantly, including ischemic heart disease and stroke. And this is the GBD map of all neurological disorders. And as you see, Iran is in the green zone. So not bad, like many other countries around. And this is the death and DALI of neurological disorders in Iran compared to the median global death and disability rates. And as you see, it's not much different. And this is our region. I mean the North Africa and Middle East region that we belong to. And you can see the prevalence of neurological disorders like stroke, migraine, Alzheimer. The fourth one is epilepsy, and the fifth one, meningitis, in the region of Middle East and North Africa. I'm sorry for my voice. I have just recovered from COVID. So, and this is the burden of neurological disease, the 10 main causes of death and disability. In Iran, stroke accounts for 37%, headache disorders 27%, Alzheimer around 10%, and CNS tumors 5%, epilepsy 4.8%. And this five first categories account for 84% of burden of neurological disorders in Iran. According to stroke, which is the main cause of disability in Iran, you can see the situation compared to the rest of the world. It's not bad. We're a little bit less than the global median incidence of stroke, but not much different. This is from the GBD study, but we have several other epidemiologic studies published from different parts of Iran, and the numbers are almost the same. The incidence is around 80 to 120 per 100K annually. Regarding neuroinfectious disease, which used to be a problem in Iran, they are not significant anymore, like TB meningitis. We don't see a large number in the recent years. Poliomyelitis is almost eradicated. Leprosy is very, very rare now. I see like one leprous neuritis because I'm a referral of neuromuscular disease each year, and for cerebral malaria, it's very rare now. Neurocystic sarcosis was never a significant problem in Iran, and SSPE, which we used to see when I was a resident very frequently is in Iran, is now completely gone because of the very good coverage of measles vaccination. A few words about neurology workforce. As I mentioned, we have more than 1,400 registered adult neurologists and 215 child neurologists. Most neurologists are general neurologists, and less than 10% are specialized in a specific field. According to World Atlas of Neurology 2017, the median number of adult neurologists globally is 0.43 for 100K, and for East Mediterranean region it's 0.77, but in Iran it's 1.78, which I think is a good number. And for child neurology, it's the same. So the number in Iran, it's more than the global median. So we have some advantages. We have good number of neurologists trained in the past few years, and the gender balance is appropriate. Female applicants for postgraduate neurology training now outnumber the men. For our university, we had 12 residents this year, and 11 of them are female residents. So they like neurology very much. Neurology residency is very competitive in Iran, and the disadvantages is the uneven distribution of neurologists in the country. So we have enough numbers, but most of them are placed in major cities and in border zone areas, and in smaller cities we don't have enough number of neurologists. We don't have enough fellowship training positions available, and some critical fellowships such as neurocritical care, neuro-oncology, neuro-ophthalmology, we don't have available in Iran. And a significant problem in the recent years is the immigration and the early retirement of some specialists because of bad working environment and financial issues and other problems that we're dealing with. Advanced neurological services are available. We have stroke care units all over the country. We have a good network of stroke and a good stroke registry. All stroke patients are registered, and RTPA is available everywhere in the country. And we have a few comprehensive stroke centers that can do vascular intervention and sophisticated vascular surgeries. So we also have several LTM and epilepsy surgery facilities, a few sleep medicine centers dedicated to neurological cases, and also movement disorder clinics, functional brain surgeries, DBS, advanced neuromuscular centers, which can do sophisticated EDX studies and muscle pathology, and also comprehensive MS centers and multidisciplinary ALS clinics. We have developed many national guidelines in the past few years. The main ones are for acute stroke, multiple sclerosis, myasthenia gravis. We also have some guidelines for rare disease such as SMA and Pompe, and also for IVIG, plasma exchange, spinal cord injury, and others. And there are others in development. Now, I'll talk a few words about the challenges. Most of them are beyond neurology. There are problems that we have in our healthcare system that are related to the government, to the financing. There is lack of effective healthcare policies and limited healthcare resources. especially in recent years due to sanctions and to the bad financial situation that are dealing with. This causes growing out-of-pocket payments and lack of access to medical databases and full-text journals. This has caused great problems for us in the recent years for education and for research. We still don't have EMR, effective EMR, and we don't use telemedicine effectively. Research has had some difficulties in recent years because of the limited resources, and as I already mentioned, immigration of neurologists is a major problem in recent years. There's a lack of enough fellowship training positions, as I already mentioned. There's unequal distribution of neurology workforce. We have neurology nurses and technicians, but they're not academically trained. They just get trained in practice. And there's a lack of neuro rehab facilitations. We have access to advanced genetic and immunologic studies, but these are not covered by insurance. They have to be paid by the patients, very expensive, and only available in the private sector. And another major challenge is the high price of new technologies and the new medications like the gene therapy, the monoclonal antibodies, enzyme replacement therapies. These are very costly and are and will cause great difficulties for our healthcare system in the future and now. So I have a few recommendations. We need a health system reform. We need to integrate core packages of neurological care into routine primary health care, reduce the cost and improve the supply of effective drugs for neurology. We had the opportunity to produce and manufacture many of the neurological medications locally in Iran as generic drugs and biogeneric drugs. We have some expensive drugs like rituximab and ocrelizumab and eculizumab manufactured locally. So this helps us to reduce the cost, but we have a long way to go. We should increase the public awareness of modifiable risk factors, electronic medical records, and financial resources for neurological care. We need to improve our international collaboration in education and research, develop more guidelines, develop more advanced neurological care facilities, and provide neuro-rehabilitation. So thank you for your time.
Thank you, Prof. Nafisi, for a comprehensive overview of the burden and challenges in Iran. This is quite impressive. Any questions? Prof. Wasai looks he wants to ask some questions.
I just wanted to ask one question, Dr. Nafisi, that how much of this care is provided by the government and how much is provided by the private sector? Because this is kind of quite different, I think, across regions. So what's the proportion?
I think it's like 60% public and 40% private sector.
Yeah. I want to ask about the neurology training over there in Iran, Prof. Nafisi. You mentioned it's very competitive. Can you tell me the duration of years the neurology has to be trained, whether they have to do internal medicine first or they can go straight to neurology?
They can go straight to neurology. So we have MD programs in Iran. So general practitioners already have passed their internship. Then there's a national exam. They enter neurology. It's 4 years. So it's 4 years neurology, and then they want to go to fellowship. It depends on the fellowship. It's 12 to 18 months for fellowship.
I see. Okay. Any more questions from the floor?
You have an exit exam or just the training?
Yes, yes. We have annual exams, but the main exam is the board exam. They have to pass a pre-board and then a board exam to graduate from neurology.
Okay. And now, do you train people from outside Iran, like the system, like from other places, like Pakistan or Afghanistan, they can go to Iran and get training? Is there a facility, or is all training in Persian or in English?
They have to learn Persian because the patients cannot speak English. Most of the patients cannot speak English. So they usually come to Iran. We have a few from Afghanistan. We had one resident from Afghanistan that is already in training. We had 2 residents from Lebanon that came here. They were here for a while and they learned to speak English, to speak Persian. After a few months, they started their residency program. So they can start, they can come to Iran, but they have to learn Persian to get allowed to see patients and get good training. So this is a must.
Professor Wasa, you want to send your residents to Iran?
Sure, why not? Very good training in certain fields.
Yeah, it looks impressive. What you've done there in Iran. Okay.
You're welcome.
Yeah. I don't see any other question. There's one last one. I am interested in fellowship in clinical pharmacology. Is there any opportunity available in Iran? This is probably a different.
I think, but it's far away from
not neurology.
but we have courses, residency courses of clinical pharmacy, and I think it's a 4-year residency. You can apply.
Okay, so thank you very much, Professor Nafisi, for the talk. So next, we have our own Professor Wasai, who is the Professor Section of Neurology at the Department of Medicine, Aga Khan University, Chair of the FHS Research Committee, Aga Khan University, and his talk is on the burden and challenges of neurological care in Pakistan. Professor.
Thank you, Hamidun. Thank you, Dr. Basri, for introduction. Haris, could you please share my slides?
Sir, we are sharing in a while.
Okay. So we'll be discussing about burden of neurological diseases and care available related to neurological diseases in Pakistan. And I think this has been a great experience to learn about care in Afghanistan and now Iran. So I will start my presentation. There's no conflict of interest related to this presentation. Next slide, please. Now, if you already know that overall burden of neurological disease is around 6.5%, that's the global burden, but it is kind of low in lower income countries, which is about 4 to 5%, and that the reason probably that they have a less aging population and they have less neurologists and diagnostic techniques. So that's probably one reason why we have low prevalence or burden of neurological disease in low and middle income countries, and it's very high in high income countries. But in the places where you have more neurologists and you have more diagnostic facilities, the prevalence or burden of neurological diseases becomes high. So it's all related to diagnostic facilities and availability of the diagnostic test. Overall death and disability related to neurological diseases is very high across the globe, and that is very true for the developing countries, especially OIC countries and especially Pakistan. Next slide, please. So this is a WHO slide, which basically tells that what is the overall death and disability related to neurological diseases. Next slide, Haris. Yeah, if you can see this slide, that total Delhi's related to neurological diseases is higher as compared to TB and as compared to heart diseases, respiratory diseases, digestive diseases, AIDS and infection. And this is very important slide because for the policy makers and for the countries who are struggling with the neurological care, that this is something they have to understand, that overall burden of neurological diseases is high across the globe, and it's going to be high in future as we get to the aging population. So this neurological diseases is going to be very, very important to be taken care of, and neurological training is going to be very important in future if you want to improve the neurological care or improve the health care of the personnel. So this is very important slide for the future, that this is one of the most important area of the healthcare, which is going to be which is still in the current practice, but it's going to be very important in future, that we have to pay attention to neurological disorders. Next slide, please. And out of all the neurological disorders, I think the most important disease which is causing disabilities and death is stroke, which is about 55%. And then you have dementias, migraine, epilepsy. So these are very important areas. Tetanus is still very important part of death and disability across the globe, especially in the developing countries. So this is important, and this is going to be important in future. And this is why I think we need to work together to take care of these diseases, prevention of these diseases, and treatment of these diseases in future. Next slide, please. As far as the death is concerned, I think stroke is the single most important cause of death across all neurological problems. Now, the burden of neurological diseases is very high in developing countries. Some of the recent data is showing the data is available, population-based data is available from like India, which is pretty much equals to data in Pakistan, and Saudi Arabia data is also available. And they have shown that about out of 1,000 population, about 100 to 150% suffer from neurological diseases. So which is still a very high number, which is like 12, 13, or sometimes 15% of the population is suffering from neurological diseases. Next slide, please. And this neurological disease of the Pakistan, what information we have right now is basically tip of the iceberg. So a lot of information is not available yet because we don't have a very good population-based data of neurological diseases. But whatever data we have is pretty scary, and that tells that, you know, a lot is going on, and neurological diseases are contributing a lot toward death and disability of people, but we still don't know very well, and that has to be known, and that has to be taken care of in future. Next slide, please. So in burden of neurological disease is largely based on hospital-based studies. We don't still have a population-based survey of neurological diseases. So we don't know the incidence or prevalence of major neurological diseases in our country. But we have some estimates, and we have calculated data based on whatever available information is. So this is one important area that has to be done, and that has to be done not only in Pakistan but other developing or part of the OIC country, that we have to know the exact population-based burden of neurological disease in country. Next slide, please. So Pakistan, just a brief introduction for people who are not well aware of Pakistan. We are 224 million population. We are number 5 in the world in terms of population, located in South Asia. We have a pretty young age for 22.5 years is the median age of the population. Still, literacy rate is 55%. So this is something which an area which we are still struggling to improve the literacy rate. Our urban population is about 40%, and our rural population is about 60%. So this is also an important part. We are considered a middle income country. So our GDP per capita is $1,500 per annum, but we are like number 181 in the world. So our kind of GDP is very low as compared to other parts of the country, and that's why we have so much problem with the healthcare facilities, which we'll discuss in the next slide. Next slide, please. Life expectancy. Go back one slide. Okay, life expectancy in Pakistan is about 67 years. It's low as compared to like Japan, which is 90 years, and low as compared to Western countries, which is about 75 years. But it's pretty comparable to the regional life expectancy like India and Bangladesh. Sri Lanka has slightly a higher life expectancy. Our total health budget is less than 1% of GDP. And this is, I think, one of the important issues related to healthcare in Pakistan, that as we heard from the Iran, which they spend like 8% of their GDP on health, Pakistan spends like less than 1% of GDP, and this is basically translates to like less than $11 per capita per income. So the healthcare in model in Pakistan is that it's usually 70% of the healthcare is out of pocket. So it goes to the private hospitals and private practices, and this is a very important area for related to healthcare, and not only related to healthcare but for the neurological care too. We have a very high burden of hypertension. 34% of our population is hypertensive, which is more than 45 years. We have a very high population of diabetics, so more than 10 million diabetics. Tobacco use overall, which is includes smoking and chewing tobacco, is about 23% of the adult population. And we are one of the most polluted part of the world. So if you look at one of the most polluted cities in the world, maybe 3 or 4 cities of Pakistan, the large cities, will be among the top 10. So our air pollution index is 130 to 250 in large cities. So these are significant important risk factors related to neurological diseases across the globe, which are also present in Pakistan, which contribute a lot toward neurological diseases. Next slide, please. As far as stroke is concerned, which is one of the most important neurological problems in Pakistan, it's about stroke prevalence is about 1,200 per 100,000 population. We have a pretty young stroke population. Our mean age of stroke is 55 years, which is pretty much 10 years younger as compared to Western population, or even 15 years younger as compared to Far East population or European population, where mean age of stroke is about 70 years. So we have a pretty younger age of stroke onset. And on top of that, we have a very huge young population with stroke, like less than 40 years. So about 20% of our stroke is less than 40 years, which is huge. And that is very high as compared to other developed countries, where the youngest stroke, which is less than 45 years, is 5 to 9%. We have a huge burden of stroke in women, 60% of our stroke in women. And a part of that stroke is related to pregnancy and postpartum stroke. So this is also an important contributing factor related to stroke in Pakistan. Our proportion of intracerebral hemorrhage is 25%, which is again very high as compared to developed countries, where it's about 10 to 15%. And this basically means that a huge population of hypertension, which is undiagnosed or untreated, or if it's treated, they are not appropriately treated. So that's why we have a huge burden of intracerebral hemorrhage. Our stroke mortality is high. 30-day mortality is 16%, and 1-year mortality is 40%. And that is also because of lack of facilities to treat acute stroke patients. Most of the stroke patients do not get admitted to a stroke unit, so they go to a general medical ward, and sometimes they even are not admitted to the hospital. And that's what contributes to a huge mortality related to stroke. So 40% people who have a stroke, they die over a period of time. We also have some unique risk factors which are related to stroke. So we have a huge burden of rheumatic heart diseases, which is basically an infectious problem. So our 7% of population has rheumatic heart disease, and this is based on population-based data. Hepatitis B and C are very common across population. So 10% of population is infected with hepatitis B and C. And we have a huge burden of intracranial diseases of the brain. So 30% of our stroke population, they have intracranial disease, especially affecting middle cerebral artery or anterior posterior cerebral artery or intracranial internal carotid artery. So these are some of the unique risk factors our stroke population have as compared to other parts of the country. And this basically, these are very important because they translate into very high mortality. And this basically describe the poor quality of care related to stroke in Pakistan. Next slide, please. Now, if you look at the World Stroke Organization stroke framework, our 85% of our stroke care is basically minimal healthcare services. So majority of patients do not get an essential stroke service care. So they just get minimal stroke service care. Only 15%, especially in the large cities and private hospitals, they get essential stroke services. And only 1% of the stroke services or 1% of the population is basically exposed to advanced stroke care, which is basically few private hospitals in large cities. So none of the government sector hospital, they are able to provide advanced stroke care. So that's this is one of the major issues, because a good quality neurological care and good quality stroke care is only available at the private hospitals with to the few people who can afford that kind of treatment. But for majority of the population of the country, which is 85%, we are not even able to provide like the essential stroke care, and very basic and minimal health care is available. And this is something which is important for future policy making and improving stroke care and neurological care, that we have to move this 85% of the minimal health care to at least some of the essential stroke services. So about 20, 30, 50% of the people should be able to get essential stroke service, and at least 5 to 10% people should be able to get advanced stroke services to improve outcome of the stroke in Pakistan. Next slide, please. Stroke services in Pakistan, neurologists, there are about 240 neurologists in Pakistan, so that's pretty much 1 per million. Population is 224 million, but we have very few stroke experts in Pakistan. So most of the general neurologists, they deal with all the stroke, and most of the general medical doctors, basically, they see the stroke and stroke are involved in stroke care. We have 10 stroke units in the country, 8 private hospitals, and 2 are in the government and public hospitals. We have about 250 CT and MRI facilities in the country, but 80% of those are private. And for 70% of the people, usually you can get a CT scan or MRI within 3 hours. So it's pretty much located all across the country, but that's usually a private facility where you have to pay to get a CT scan or MRI. TPA is available in 6 centers in Pakistan, which are all private hospitals, so they're still not available in any of the government facility. Drug Regulatory Authority of Pakistan, they have recently approved TPA to be used in Pakistan, but it's not yet marketed by the company, the Boehringer. So it's not available at all centers in country. Only centers who import drug from the outside, they have this available. So this is, I think, important. I think once the TPA becomes available throughout the country, hopefully it will translate to better stroke care and establishment of more stroke units and better quality of stroke care related to acute stroke. Thrombectomy services are provided only in 3 centers. There are 2 in private hospital and one public hospital. Rehabilitation centers are mostly outpatient. So there are more than 200 outpatient rehabilitation centers. There are more than 3,000 doctors of physiotherapy in country. And most of the physiotherapy in our part of the world in Pakistan is home physiotherapy. So because there are no inpatient rehabilitation facilities, so most patients who get a stroke, they go home and they get a home physiotherapy. Either a physiotherapist come to the house or a family learn how to do physiotherapy by themselves, and they start doing physiotherapy to their family members and the patients. So this is how most of the rehabilitation system works here in Pakistan. Next slide, please. Now, stroke is high, and the risk factor is pretty much well known. So we estimated have about 350,000 new stroke every year, which is pretty much 1,000 per day, and we have a stroke mortality of about 400 per day. So it's very high, 1,000 stroke and 40% mortality, and we have a very high post-discharge mortality. So usually patients at 30 days, their mortality is 16%, up to 16%. And once they go home, they kind of don't get the optimal stroke care. So they kind of become non-compliant to the medication. They don't get the right therapy, rehabilitation, or they become depressed. So we have a huge mortality within like 12 months. So this is something very important area for intervention in Pakistan in future, that we should be able to reduce the long-term mortality related to stroke in Pakistan, which is very, very high as compared to any other part of the world. Next slide, please. Now, Pakistan has a very is a high burden of stroke risk factors. So 33% of Pakistani population above age 45 is hypertensive, which is probably one of the highest in the world. About 1/3 of these hypertensive patients are unaware of their hypertension, and about half of them, they are not appropriately treated for high blood pressure. In 2000, there were 5.2 million diabetics. Now it's 13 million diabetics in Pakistan, and we are number 4 most populous country for patients with diabetes. And unfortunately, this diabetes prevalence is going up, which is a very important problem, because now we are seeing more and more of diabetes related complications, and this diabetes population is increasing in number. Prevalence of smoking is 14 to 21% adolescents, and more common in men. But we have also a huge burden of non-smokers or chewing tobacco population in Pakistan. Next slide, please. Next slide, Hans. So prevalence of tobacco is very high, especially the chewing tobacco. People in Pakistan use a lot of gutkha and chewing tobacco as compared to, and that's also increasing. Haris, next slide, please. I think it has stopped sharing, so can you reshare the screen?
I think we'll reshare because we are changing from here, but they are not visible to you.
Okay. So
Okay,
maybe stop sharing and then start sharing again.
Do it again. Can you see it now? Epilepsy?
No.
Okay, let me just do it again.
You stop first and then restart resharing.
Okay. Is it visible to you, sir?
Not yet.
वो ये बंद करो, एक बंद करके बंद करो?
You have to stop sharing first and then start sharing again. Sometimes it happens in Zoom that it kind of hangs. Okay, now we move.
I think there was some problem with the PowerPoint. It was not responsive.
Okay.
Yes, yeah.
Yeah. So now, other than stroke, I think epilepsy is another important problem in Pakistan. It's about 1% of the population, and we have more than 2 million epilepsy patients in Pakistan. Our highest prevalence is around 30 years of age. It's very high in rural areas. Now, the burden of epilepsy is not fully evaluated and understood in Pakistan. So we have some regional data, population-based data to suggest that what's the population of epilepsy in Pakistan. Next slide, please. But epilepsy in Pakistan is also has a lot of implications related to treatment, because more than half of the patients are located in the rural areas, and treatment gap is very, very high. So less than 50% of epilepsy patients, they are basically able to receive the right treatment or optimal treatment of epilepsy. So we have a huge burden of uncontrolled and undiagnosed epilepsy. A lot of stigma is among populations, so very poor awareness and lack of treatment. And that's why epilepsy in Pakistan is contributing toward a lot of disability. So 15 to 20% of people who have epilepsy, they kind of become disabled, especially women. They are unable to work, they are unable to go to school or continue their education, and they are unable to spend like a healthy, a good quality life. And so that's one of the major problems related to epilepsy care in Pakistan. Next slide, please. Tetanus, rabies, and polio, these are the three infections which are still prevalent in Pakistan. There are more than 5,000 deaths related to rabies in Pakistan. There are a lot of dog bites in country. There are about 300 to 400,000 dog bites per year in country. We have a vaccine available for rabies in Pakistan, but very few people are vaccinated. And we also have rabies immunoglobulins and toxoid available in the emergency rooms. But again, not many people who are able to get that toxoid or that immunoglobulin. And that's what is still causing a lot of deaths related to rabies in Pakistan. Now, tetanus, in 2010, we have 58,000 deaths related to neonatal tetanus alone. Tetanus has gone down, but 30% deaths in neonates and 17% infants related to tetanus in Pakistan. So tetanus, which is a totally preventable disease with vaccine, is still prevalent in Pakistan, and a lot of people still suffer from tetanus and they die of tetanus. Polio is still prevalent in Pakistan, though very low numbers now. In 2021, we have only 5 reported cases of polio. So this infection is going down, and hopefully we will be able to eradicate polio in next 4 to 5 years from Pakistan. But tetanus and rabies, I think we need to work more hardly and strongly. Our Pakistan Society of Neurology, they have established a tetanus and rabies task force many years ago, but we have not been able to convince the government to do aggressive treatment plan and campaigning for eradication of tetanus and rabies in Pakistan. So tetanus and rabies continue to be a major healthcare problem in Pakistan, especially to neurological diseases. Next slide, please. Other issues related to neurological problem is TB. TB is 7th leading cause of death and disability around the world. And Pakistan ranks number 6 in terms of burden of TB population in the world. And TB contributes, central nervous system TB is about 5 to 10% of all TB cases. Next slide, please. But if you talk about the mortality and talk about the disability, 40% of mortality in TB is related to CNS tuberculosis. And intracranial tuberculous lesions, they account for 10 to 30% of intracranial masses in our part of the world. And globally, I think HIV epidemic is mostly responsible for TB cases in developed countries. But in our country, HIV is very low, but CNS tuberculosis is very, very high. So, and the death and disability related to CNS tuberculosis is very high. So it's very common because we have CNS tuberculosis patients all the time in our hospital. And our hospital, there is a private hospital. A lot of government hospitals, they have a much higher burden of CNS tuberculosis, and they tend to admit a lot of these patients. And it is associated with high disability and death. Next slide, please. Related to CNS tuberculosis. So this is a study we published that out of 400 patients, about only 32% patients, they were normal at 1 year, and 18% died. And a lot of about more than 50% patients, they were disabled at 1 year. So this is how CNS tuberculosis is. If it affects the brain, the mortality and morbidity becomes very high, and only 1/3 of the population, they are able to recover completely. Next slide, please. Neurological care in Pakistan, as far as the neurology centers are concerned, about more than 70 neurology centers in the country. There are only 3 pediatric neurology centers. We have about 10 pediatric neurologists in the country. Some out of these 70 centers, there are 22 government hospitals and others are private hospitals. 90% of the neurological care is available in only large cities, and about 300,000 patients are seen per year in OPDs. So from some of these different centers, we had a neurology database of outpatient clinics. So we collected the data for over a period of time. Or 240 neurologists, as I told you, for 224 million population. So it's about 1 per million. Our system is that our country is divided into 132 districts. And each district has a hospital which is called DHQ hospital. But unfortunately, 95% of the DHQ hospitals do not have a neurologist. So neurological care is not available at the district level, which is kind of the basic administrative unit of the country. And more than 65% of the medical colleges, they don't have neurologists. So that's why neurology training is suboptimal in the country for the medical residents and medical graduates. So this is something which is very important in our country for future improving future neurological care, that we should be able to train our doctors well in neurology, and we should be able to train our medical students well in neurology so they could take care of neurological care patients. Next slide, please. There are 10 stroke centers. I told you 300 CTs and MRIs. There are less than 100 rehabilitation centers in the country. So 42 rehabilitation colleges in the country. There are more than 7,000 therapists, most 90% of physiotherapists. There are 2 inpatient rehab centers in Pakistan. One is Islamabad and one is the spinal cord injury unit in Peshawar. So not many facilities, especially for stroke rehabilitation. There is no specific facility for stroke rehabilitation in Pakistan. Next slide, please. Undergraduate training. So far, neurology department is not essential for a medical college in Pakistan. We are talking to a Pakistan Medical Commission that neurology must be a mandatory part of all medical education. There are 130 medical colleges in Pakistan, but only 38 medical colleges have neurology department or neurology section. So 70% of the medical colleges do not have any specialists who would teach neurology to the medical students. And this is also related to low number of neurologists in the country. We think that once we have a good critical mass, like about 400 or 500 neurologists in country, we will be able to get all the medical centers and all the training centers with good quality of neurological training. So this is something which has to be improved over a period of time, and this is a very important issue for the future. Next slide, please. Now, undergraduate neurology, most of the patients who go, doctors who go through the medical college, they don't go through a neurology rotation. So it's part of the general medicine. Neurology is not part of an MBBS examination yet. They get less rotation time as compared to IENT and orthopedic surgery. And this is why once we get medical graduates from country, they have very little knowledge about neurological diseases and care. Next slide, please. As far as postgraduate training is concerned, there are two tracks. So there's the FCPS, which is called Fellow College of Physicians and Surgeons, and there is MD track. There are more than 120 FCPS graduated, 25 to 30% are out of country. And this is one issue related to neurology training in Pakistan, that we have a huge brain drain. So as soon as people pass out their neurological examination, they go to Middle East or other parts of the world where they get like very good salary and other packages. Currently, we have about 104 FCPS trainees, 21 supervisors, and 17 training centers. And we are graduating about 25 to 30 neurologists every year from these centers. So kind of slowly picking up the number of postgraduate neurology training. It's a 3 years training program. Next slide, please. Go one slide back. Yeah. So we get 20 to 30 FCPS neurologists every year. 50% go out of country. That's one problem with it. After you train people, they'll go out of country. We have only subspecialty training in neurophysiology and stroke, and that's only available at our centers. We are in process of getting approval from College of Physicians about epilepsy training and neuromuscular disease training, approved training. So hopefully we'll be able to start some more fellowship programs over a period of time next year. Next slide, please. There is a large number of neurologists outside Pakistan. So there are more than 550 neurologists in USA, which are from Pakistan. There are about 40 in Canada, 40 in UK, 120 in Middle East, and about 100 other parts of the world, including Australia. So a large number of Pakistani neurology community actually live outside the country. But I think they could be an important resource for future neurology training and care in Pakistan. This is also a good data, and they could also contribute toward good neurology training in Pakistan and other parts of the world. Next slide, please. So these are the challenges related to neurological care in Pakistan. We have a very high burden of neurological diseases. We think that about 10 to 12% of population suffer from one or the other neurological problems. The problem with the neurological diseases is that they are a very low priority as far as the health policy is concerned at all levels. There are lack of neurology positions across the country in the medical colleges and large teaching hospitals. There's brain drain, so a lot of neurologists moving out of the country. And that's why we have a shortage of neurologists across the country. We also suffer from lack of data related to neurological countries. There's a lack of subspecialties in country. So most of the general neurologists, they have to provide all the care to the very specialized patients. Next slide, please. This is some of the papers we recently published. This was a paper published in neurology. Next slide. What we think is the way forward for neurology in Pakistan. I think to start with, I think we need a national health survey for mental and neurological diseases. We are working with the Pakistan Health and Research Council, Higher Education Commission, and WHO to conduct such a survey. So we will have an exact prevalence of neurological diseases in Pakistan. This is one thing. Number two, we are working to make a mandatory neurology training and examination at the undergraduate level, and we are working with the Pakistan Medical and Dental Council. We are trying to increase neurology training positions so we could train more neurologists throughout the country. And our society is also very strongly working in the area of public awareness, so improve awareness related to neurological problems. And we are also actively involved in advocacy, policy making, and priority setting. So hopefully this will translate in future to better neurological care across country and improve neurological training and education across country. Next slide, please. This is one of the papers we published many years ago, tetanus and rabies eradication in Pakistan, which is a major problem in Pakistan. Next, please. This is also related to tetanus and rabies, and we established a task force at the global level with India and Bangladesh to get rid of Africa and Asia of rabies and tetanus, and this is also still a work in progress. Next slide, please. And that is still a problem in some parts of Asia. So neurological care in Pakistan. Next slide. This is also, we suggested that a national health survey should be done in Pakistan to understand the neurological burden of Pakistan disease in Pakistan. Next slide, please. This is a editorial related to cost-effective interventions of chronic disease, especially high blood pressure, stroke, diabetes, and cancer. Next. Dementia is also, we have now an aging population. So dementia is also becoming a problem in Pakistan, and maybe in future, we see a high burden of dementia in Pakistan. And this is, I think, we need to understand and take care of right now to decrease the burden and to improve the care. Next slide, please. This is a stroke in Pakistan. This is a paper we published in International Journal of Stroke. Next slide, please. And this is one of the editorial related to stroke epidemic in Pakistan. Next slide, please. So at the end, I would like to thank all the audience and the participants and our chair, Dr. Hamidun Basri, co-chair, Dr. Salim Badich, and comstech for organizing this event and gave us a chance to share burden and care of neurological disease data from Pakistan. Thank you very much.
Thank you, Professor for the talk. Quite interesting, and probably I'll start off with one question. What about the healthcare system? Is it government subsidized, or is not?
Well, mostly it's private. So 70% of the healthcare is all out of pocket and private. So people have to pay from their pocket. 30% is government and other like NGOs. They are operating a lot of hospitals and other facilities. So 30% is kind of government or subsidized, and 70% is private out of pocket.
So it's quite expensive in terms of the.
It is quite expensive.
If they have a stroke, for example, for thrombolysis would be very expensive.
It is
thrombectomy.
Usually, exactly, and that's why the problem is that a lot of people. It's a poor country, and very few people are able to afford the expensive neurological care. So that's why we have a huge mortality related stroke. 40% is a very high mortality related stroke, and it's because a lot of people, they don't get the right care which is needed. The government hospitals are unable to provide that care, and the private hospitals, they provide good care, but a lot of people are unable to afford that kind of care. So that's the problem.
What about personal insurance? Is that something common?
Not very. Only people who work in like big organizations or companies, they have some kind of health insurance, but less than 5% of the people who have health insurance. Now, the healthcare system in country, they have started a kind of health insurance only for acute, urgent care for heart diseases and surgical, but that's still very like in the early stages. So it's not prevalent to everyone. It's not present for everyone.
Yeah, it's quite a challenge for you then.
It is,
because of that. Yeah. There's a few questions from the floor. I'm not sure whether you want to take this. Is there any gene therapy or stem cell therapy?
Not yet. Not yet. Now, well, we don't have a therapy. We are at our university. We have a stem cell research center, but there's no stem cell therapy available to patient. It's not even FDA approved for any of the diseases. So a lot of people, they like to have stem cell therapy, but it's not available in Pakistan. It still is in the research phase. So there's a gene therapy is available, not yet in Pakistan, but hopefully will be soon available in Pakistan for some of the rare pediatric neurological diseases, but not yet available in Pakistan.
I see Dr. Salim is here. Any question from Dr. Salim?
Comment on neurological burden in Pakistan.
He's from Pakistan too, yeah. Okay, there's one question because hi, Dr. Salim.
There are a couple of more questions in the chat, if we can take them.
Can you read them? Because I cannot keep up with
it. There's one question from Ms. Hafsa. Sir, you didn't discuss about Alzheimer, autism, dementia, and Parkinson's. Do we have less ratio of these diseases?
Well, we have a good number of autism patients. It's much less as compared to developed countries. Dementia and Parkinson's, they are growing in numbers. Now, our population, which is like more than 60 years old, is only 7% of the country. So we have like only 7% of the population country, which is more than 60 years old. So we have a less elderly population. That's why we have less number of patients with Parkinson's disease and Alzheimer's disease. But that number is growing. So that's going to be a future challenge. It is still a challenge. We get to see a lot of patients with Alzheimer's and Parkinson's disease. Now, autism is also an important problem. Again, the problem is diagnosis. We don't have a lot of pediatric neurologists in country or pediatric psychiatrists or doctors who are trained in diagnosing autism and treating them well. So that's why it's very underestimated, and we don't know the exact prevalence of autism in children. So probably it's high, but it's not yet known, and the care is available for very few patients. So that's one of the problem areas in Pakistan.
It seems that there are many more questions coming in. Do we have time?
We'll take one more.
One more.
We have time for we have 4 more minutes.
Okay. Muhammad Ilyas, he has said that what is the number of epilepsy cases being misdiagnosed and mistreated in Pakistan? What is their proportion, and can we have a population-based survey on them to find out?
There was a population-based survey about 20 years ago in Pakistan, and that survey showed that 50% of the patients who have epilepsy, they were not diagnosed. So that's one thing, that they were not diagnosed. And now those 50% who were diagnosed with epilepsy, so at least they had diagnosis, about 30% of them were getting treated. So 20% were not getting treatment. So that was 20 years ago. Since then, we did not have a population-based survey, but in my opinion, there are about 50% of the epilepsy patients which are not diagnosed or treated. About 50% they are diagnosed and treated, may not be optimally treated, but they are treated. So still there's a huge treatment gap related to epilepsy. Partly is related to awareness, that a lot of people are not aware that this is a neurological condition or disease. A lot of think that it's kind of a supernatural thing or spiritual or something like that. But partly is that people are scared of telling others that they have epilepsy or their kid have epilepsy or their son or daughter have epilepsy. They kind of hide it as compared to getting to the right treatment. So it's, but I think it's 50%. That's still huge.
Okay, thank you, Professor Wasai. I think we'll end the talk. One question to the organizer. The fourth talk is on or not? Because it is listed here as from Albania.
So Dr. Kruja will not be presenting her talk. So the next talk would be the recorded lecture by you. So for that, I would ask Dr. Salim.
Sure, thank you.
Dr. Salim, could you introduce Dr. Hamidun Basri in detail?
Thank you, everyone. The next speaker is our chair of the session, Professor Hamidun Basri, President APAN from Malaysia. He will talk on burden and challenges of neonatal care in Malaysia. Professor Hamidun Basri, please.
So now we'll play the recorded lecture of Dr. Hamidun Basri. Just 1 minute.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh. First of all, I would like to say my greatest thanks to the organizer of the first OIC International Conference of Neuroscience, especially to Prof. Wasai, a good friend, old friend, for inviting me to give this talk. And my challenge is to give you an overview of the burden and challenges of neurological care in my country, in Malaysia. So for the next 20 to 30 minutes, please bear with me on this topic. This is where I am currently practicing in one of the university hospitals of University Hospital. The hospital is only about 3 years old, and we started our services for the last 2 years, unfortunately during the COVID pandemic. So in general, I would like to tell everyone about our country, Malaysia in general. It is founded in 1411 by a Malay Sultanate and a Muslim Sultanate from 1411 to about 1511, 100 years before the Portuguese invaded us for another slightly more than 100 years until 1614, where the Dutch came in and beat the Portuguese, and they also colonized us until the British came in 1821, and then Japan, World War II for 3 years before the British came back, until we gained independence in 1957. And in 1957, we were called the Federation of Malaya, which is the peninsula, including Singapore in Penang. And in 1963, Malaysia, the state of the country, Malaysia was formed, which comprised of Malaya, Singapore, Sarawak, and North Borneo, or Sabah. A few years later, Singapore pulled out and left with Malaya, Sarawak, and Sabah. So that's a bit of history on my country in Malaysia. We are a multi-ethnic, multicultural, multi-religious country. So a lot of diversity with our people. The ethnicity, you can see majority is the Malay Muslims, and then followed by the Chinese, and then the Indians, about 6%, Chinese 20%, and the Malays 61%. Others are other ethnic groups. So such a diverse population, melting pot, you can imagine the multicultures, and we do like food. So we have lots of food ranging from multiple ethnic food to the fusion ones. So quite interesting. It's not moving. Because you will probably need to. The slides are not moving. Taste all our different variety of food. We are also multi-religious, where the majority are Muslims, about 61%. All Malays are Muslims, followed by Buddhism, about 20%, and Christianity, about 9%. So if you go all over the country, of course, different states has different composition, but mostly Muslims, and you see a lot of mosques. And one of the mosques that I put up here in this picture is the one in the capital city of Putrajaya, where it's a huge mosque. And I myself, when I first stepped in, was in awe of the beauty and the complexity of the place or the mosque. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And one of the mosques that I put up here in this picture is the one in the capital city of Putrajaya, where it's a huge mosque. And I myself, when I first stepped in, was in awe of the beauty and the complexity of the place or the mosque. In terms of population, the growth, like any other developing, almost developed countries, the growth is rapid. But for the last few years, we have seen that because of the increasing elderly population, the usually bottom heavy is shrinking, and we are seeing more of the elderly population. And with that, with increasing age, population growth, comes the lifestyle changes, the risk factors, the food that I mentioned. There are an increased numbers of incidences of non-communicable diseases, and specifically in neurology, stroke, and dementia. So you can see our growth is between the first and the second, which is not too rapid and not too slow. And we are seeing more of the elderly geriatric population. This is an example of what we did. We have a National Neurology or Neuro Registry, or NNR, and one of the registry that I want to highlight is stroke, and it was published about 5-6 years ago, where we can see there's an alarming increase in the incidence of stroke when WHO Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh. In terms of population, the growth, like any other developing, almost developed countries, the growth is rapid. But for the last few years, we have seen that because of the increasing elderly population, the usually bottom heavy is shrinking, and we are seeing more of the elderly population. And with that, with increasing age, population growth, comes the lifestyle changes, the risk factors, the food that I mentioned. There are an increased numbers of incidences of non-communicable diseases, and specifically in neurology, stroke, and dementia. So you can see our growth is between the first and the second, which is not too rapid and not too slow. And we are seeing more of the elderly geriatric population. This is an example of what we did. We have a National Neurology or Neuro Registry, or NNR, and one of the registry that I want to highlight is stroke, and it was published about 5-6 years ago, where we can see there's an alarming increase in the incidence of stroke when WHO also called for global public health emergency. You can see the exponential increase, and this is really worrying. So just a bit on our society, or the Malaysian Society of Neurosciences. So the idea of Malaysian Society of Neurosciences came about in 1986. And in 1989, it was fully registered, and it was called the Malaysian Society of Neurosciences, where the majority of its members are neurologists. And then there are also neurosurgeons and neuroscientists. But almost half are neurologists. And at the moment this year, there's roughly around 350 members. So slightly low, lesser than 200 neurologists in the country. And this is to cater for 31 million population. So a bit about the training of neurologists in Malaysia. Like any other Commonwealth countries where we were colonized by the British, initially the 5 years of basic medical degree, followed by 2 years of housemanship. Initially it was 1 year, but we have increased it to 2 years for the last 10 years. 2 years of service as medical officer in internal medicine, so they are exposed to internal medicine before they can join the internal medicine specialist training for 4 years, either masters or an internal medicine for professional, what we call the parallel program, which is MRCP based. And after 4 years, if they pass, they will go through 3 years of general neurology with 1 year stint overseas, preferably, but because of the pandemic, the last few years, all the 3 years are done within the country, but we switch places from one center to the other. And if they want to do specialty, for example, in movement disorders, epilepsy or stroke, they have to spend another 2 years of stint overseas, preferably, but because of the pandemic, the last few years, all the 3 years are done within the country, but we switch places from one center to the other. And if they want to do subspecialty, for example, in movement disorders, epilepsy or stroke, they have to spend another 2 years of apprenticeship. So it's a long process, more than 16 years for a 19-year-old after finishing their basic secondary degree or diploma to go through all this to become a neurologist. So it's a long one. These are the distribution of neurologists in Malaysia. This is the peninsula, this is the Borneo side, or the East Malaysia. As in any other country, the numbers are concentrated mainly in the capital or the big cities. For example, here in the Klang Valley, 75, 12, 10, this is the Klang Valley. That comprises about 2 or 3 million people. But in other parts of the country, it's not as many. But we have made sure, the Minister of Health have made sure that most states are covered by at least 1 or 2 neurologists. If they don't have any, there'll be a visiting one. Unfortunately, the East Malaysia side, Sabah and Sarawak, is not as many because of many logistic issues, but we are trying hard to improve on that. So altogether, about 160 or 170 neurologists in the country. The peculiar or something which is different in Malaysia is that the hospital services are divided into 2. public hospitals and private hospitals. And public hospitals, they are further divided into those under the Ministry of Health, where the cost is very minimal and highly subsidized. And secondly, the public hospital under the universities or the Ministry of Higher Education, where the costs are slightly more but still highly subsidized. And the second one is the private hospitals, where it is expensive because, well, cost is a lot, and they need to earn some what do you call that, income. But it's popular amongst those who are insured with insurance, those with the corporates who are also insured, and for health tourists. This is an example of one of the big private hospitals where I'm visiting, called the Prince Court Medical Center. Beautiful hospital, huge one, and catering for the specialties and especially the health tourists. But during the pandemic, the business is a bit not as good as before. So these are the distribution of health facilities. There are altogether in 2020 reported 156 government hospitals under the Ministry of Health, compared to 219 private hospitals. It is mushrooming, yeah, the private hospitals are increasing year by year, and it beats the government hospitals and 6 university hospitals. These 6 university hospitals are huge because they cater for all specialties and on all the high-end equipments. So the distribution is a bit, for example, if you are insured, mostly will go to the private hospitals. If you are not, then they will go to the either government hospitals or the university hospitals, depending on what sort of condition they have. And we can see that with the mushrooming of the private hospitals, so the insurance that has been taken up by the population or the public has increased tremendously, because the majority of the the private hospitals are more comfortable, they are more equipped with facilities, and there are possibly better or more trained specialists there. So we can see from 2011, from 3.6%, it has jumped up till almost more than half of the population is insured, either personal insurance or corporate insurance. But the other half, although they are not insured, but mostly are under the government servants, or they are parents of government servants or dependents of a government servant. About 2 million government servants and another few millions are dependents. So they are also covered by these government hospitals and also the university hospitals. Just to give you an example of how we calculate the cost, for example, this is for stroke, yeah, for EVT and IVT, intravenous thrombolysis and endovascular thrombectomy. For example, in private hospital, the cost is between 40 to 80K ringgit, or around 10 to 20,000 US dollar for the whole cost. In a university hospital, it will cost around 20 to 30K, or 5 to 6 K US dollar, 5 to 8K US dollar, where mostly they have to buy the stents they have to buy if, let's say, they need the EVT. And in the Ministry of Health hospitals is very minimal, between 0 to 100 ringgit, depending on the registration, or whether they are from the elderly, discounted, or they are school children, which is also discounted. So this is the scenario, and neurology is also part of this healthcare, and these are the issues that we have and the scenarios that we have. Another major issue that the country has is issues with medical training. For the last probably 7-8 years, we have a high volume of medical graduates, which is from local universities and also from overseas universities. In 2015, there are 3,000 graduates per year, and since 2016, it has increased to 6,000. So double up, because I think, most parents want their children to become doctors, and if there's no limitation, then it will increase without any control. And since 2016, because of the jump, we realized that we need to have a moratorium, and since then, there's no new medical programs that is allowed. So it has been stagnated, but it has increased too because of the overseas graduates, which we cannot control. They are also coming in throngs. The doctor to population ratio in 2010 is 1:850, and in 2020 is 1:500, which is more than enough. The WHO recommends 1:600. Yeah? So because of that, there's this bottom-heavy, more junior doctors compared to the specialists, is causing stiff competition for specialist posts, and there's lack of specialized training center. As you can see in this graph, there are exponential increase in the number of new doctors, but in terms of number of specialists has been rather flat or slow in terms of the numbers. So looking at this, we need to strategize on how to increase our specialists rather than increasing our medical graduates. So most universities, including mine, we are reducing the number of undergraduates and increase the number of the postgraduates or the specialty program. Because of that, if you know about our nation's issues, these are some of the younger doctors. They are not satisfied with their condition, being given contracts and not permanent posts. So they take some petitions to let the public and the government know. So this is one of my teachers told me that the mediocre teacher tells, the good teacher explains, the superior teacher demonstrates, and the great teacher inspires. This is by William Arthur Ward. And since then, I was looking into what can be done after a certain age. What can we do to the nation to benefit the people? And what our Prophet Muhammad says, the best of people are those that bring most benefit to the rest of mankind. And being a good human is to do good, which benefit others. And what my thought was then, about 10 years ago, to teach and train young neurologists, because there are not many neurologists in the country at that time. And what we as the seniors can do is to prepare and develop a platform for them to thrive and shine, to become good neurologists and a good human being. So that was the thought when I was in this institution in one of the universities in the Klang Valley for about 9 years. I have achieved whatever I want there. And my thought was I need to build another training center. So in 2009, I moved to this place where it is in the southern part of the Klang Valley, where there are no neurology services in the southern part. So in 2009, I took up initially two apprentices to become a neurologist. The training is 3 years, so they graduated a few years later. And in 2014, I took up a few more. So when the numbers are ready, and the university at that time is depending on a hospital which is nearby. This is the Serdang Hospital, an older hospital. This is our faculty. There's a bridge there. So we started our neurology services there. There's none in 2009. So we started there. And then when it starts to develop, there are more neurologists and there are more needs for new drugs, new services. So the hospital, which is under the Ministry of Health, is not able to cope and cater for what we want, how we want to expand. So we have tried to lobby to the university, which is under another ministry. And you can see at the back there, there's a huge land where it is empty, nearby a golf course. So in 2014, with about 4 neurologists under my training, we managed to get a new hospital which is catered for specialties which is not in this hospital, and they agreed that neurology is the leading forefront of the hospital. So in 2019 here, the hospital was ready, and we started operation in 2020. So that is the platform that I thought might be beneficial to the nation, where it's not a short process, a long process. You need to train the neurologists, and then you need to lobby that this is important for the nation. And fortunately, in 2015, as you remembered, there are many trials saying that new treatment with thrombectomy and thrombolysis will improve the outcome of a stroke patient. So I've been going in and out the ministry, the higher authorities to lobby for that, and they have approved the hospital, which is dedicated to neurology, and the forefront is stroke, because stroke is the one that gets the buy-in. So our hospital is dedicated to, the emergency department is dedicated only to stroke. So these are my neurology. Initially it was a unit, now it's a department. My first trainees are Dr. Hu Fan Ki and Dr. Wan Alia here, followed by the others, Dr. Liana, and the rest, which is now a strong department in the hospital. So it's a long process, and it's still progressing, and I hope it will be good progress over the years. So this is just to share with you how this started, to lobby for actually a stroke center, but at the back is all neurology, because we practice general neurology. So when we built the center, it's not just for stroke, but the forefront, the ED, the ER is mainly for stroke. So this is what the slides that I presented to the minister, to the Director General of Health, so that they are able to buy in to give the budget for the hospital. So I told them about the devastating and disabling stroke and the most recent powerful and potent treatment in thrombolysis and thrombectomy, and the increasing window up till 9 hours, 24 hours. And from our own data, the incidence has been exponentially increasing. And when we calculated with our public health doctors, about 30,000 new patients can be saved from disability every year in Malaysia. And this will give a strong impact on the nation's well-being and long-term cost savings. So my idea then is to brand it so that it's catchy. So what we coined was the Regional Emergency Stroke Quick Response Network, or Rescue Network. So stroke rescue, so that is the catchy part, so that the higher authorities is able to buy in our requests and proposal. So why the need? I mentioned to them the small number of interventionists who can do the thrombectomy, only 7 at that time, and thrombolysis services are also not optimized. There are many delays, and thrombectomy is infrequent and in isolation, low impact, and not suitable to train people. So we need to train people, we need to train neurologists too, and there are budget constraints. So we need to identify a lead core high volume center, and many centers which is already in operation are busy with other things. So that is the opportunity for me to come in for the new hospital to be a leading high volume core center for the rescue network. And the strategies at that time that I put up was there must be a high volume center, a core rescue training center. It must train people, teach and train. And there are satellite centers around that area, which is the south of the Klang Valley, and a partnership and pooling of resources with the stroke calls, drug stands and rehab, and etc. And then after that, expansion of the rescue network to the rest of the country, and also last but not least, branding of the rescue so that people knows what it is and people comes early to the hospital. So this is the rescue network anchored by our university hospital, or HPUPM. There is a dedicated ED just for stroke. So the MRI, the CT scan is dedicated only to stroke. There's no delay. and the operation started in June 2020, and lo and behold, the pandemic comes in too. So there are some limitations during the pandemic because of the issues with PPEs and cleaning and all that. So we are not full force then. But we do have referrals since then, since 2020, almost 2 years now, from initially it was the south of Klang Valley, but now everyone sends to us because of our availability up till as far as the east side of the country to send to us the cases. And it's not limited only to stroke, but because of our strength, all neurology cases are also sent to us. So this is the timeline that we put up to the government. We are in the initial stage, but we plan to expand to the whole country. So that is what is important, so that it's not just only one part of the country that have these services that can benefit the nation, but must be the whole country that benefits. So this is our long-term plan, which needs the support from the government, especially the Ministry of Health. So this is our performance audit since until June 2021, after about 1 year plus. So total admission about more than 300, where we have thrombolysis and the thrombectomy and thrombolysis rate or intervention is 34%. So that's quite good, but we can improve further. And mean door to imaging is 15 minutes. So when you come into the door, within 15 minutes, we are able to scan, and mean door to needle is 41 minutes. There's a slight delay. We can improve on that because of BP control and so on and so forth. And we are mainly using MRI or the SCT because that's after the discussion with the IR and the radiologist, we think probably best at the moment to do MRI because of the referrals from others. So that's how we perform. These are some of the videos that that I showed to the government to lobby to them that it works. This really works. For example, on the one top left, the patient cannot. There's dense hemiplegia on the left. 1 hour after thrombectomy, he can move his left arm and legs, and 3 months later he can go back to his normal self. He's a taxi driver. He can be after our occupational therapy has agreed and certified him to drive again. He is able to drive again. So that's some of the materials that that I've used and able to get back what we proposed. This is some of the activities. You can see I think the main issue with how to maintain the motivation of our staff. So that is important that that I learned. So we must make sure that our staff are always motivated and they can see that the treatment works and they are doing this for the good of the nation and the Ummah. So you can see that this is the thrombolysis room that we have. This is the angio suite, and some of the neurologists which is involved. They are waiting in front of the ED. If the patient comes in, they go straight to MRI and they thrombolyze the patient in the ER, in the MRI room itself. So for the first 5 minutes, they thrombolyze, and then after the sequence, the DWI and flare, there's a mismatch, they thrombolyze, and after that, only then they continue with the other sequences of the MRI, like MRA. If let's say they want to do thrombectomy after that. So this, the other pictures, you can see this is one of my trainees who is helping out in the angiogram and the thrombectomy and the activities during the thrombectomy procedure. In order for us to gain the momentum, I have asked World Federation of Neurology, at that time the president was Bill Carroll, to help out, and he has, well, readily and gracefully given us a letter to support the rescue network. And he mentioned that the rescue network that we coined is a bold and important initiative, and based on the high volume center, and this will also be considerable in financial benefit to Malaysia. I think this also gives the strength of our proposal and application. And we, with the support of the association, the regional and the world association, we are able to do this together. And Alhamdulillah, we are able to get what we want, and still we are trying to maintain this and to show and to prove that what we do is of benefit to the people. So just to show you our what we have achieved in 2020, we're given the Gold Award by the Angels Initiative, and 2021 we achieved the Platinum status, and hopefully by this year we will be able to get the Diamond status based on the standards of the World Stroke Organization. So ladies and gentlemen, I'm just telling you the story, although it's not all about neurology, but my experience in how I see things and how we want to give back to the people that was given to us, the knowledge, the skills, and the most important part is how to impart the skills and how to prepare a platform for our younger generation to continue on. And may Allah bless you with long age and good health and prosperity in your life. And may Allah guide you to do good deeds till the end of our life, and may we be given Jannah. So thank you very much for listening. I hope this benefits all of you. So Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh, and have a good day. Thank you.
Thank you, Professor Hamidun. If any questions?
Hello.
Dr. Salim, we are running a bit short on time. So all the questions for Dr. Hamidun's presentation, just email them to me at hasib.ahmed@comstech.org, and I will forward them all to Dr. Hamidun to answer. Because Professor Sarfner Ozturk is already here. So Dr. Salim, I would request you to introduce our next speaker.
Okay, thank you. So the next speaker is Dr. Sarfner Ozturk. She's from Turkey and will talk on burden and challenges of neurological care in Turkey. Dr. Sarfner.
Okay. First of all, I would like to thank for this important invitation to organizing committee, and thanks Professor Wasai. And I would like to thank Professor Basti for his excellent speech before than me. My job is very difficult after his speech. Yes, burden and challenges of neurological care in Turkey, and this is always an important subject. If I mention manpower for neurological disorders in Turkey, we have approximately 100 universities and many private and ministry hospitals, and our neurology education training duration is 5 years, and we have enough rotations as UM's directions. And we have more than 35 scientific working groups for every neurological disorder. And they are working very hard for prevention and to improve treatment modalities and approaches, and also some strategies. We have 3 subspecialties: neurophysiology, oncology, and intensive care. You know, total burden of neurological disorders are mainly consisting of cerebrovascular disorders in the world, and in Turkey also this is same, because we have an aging population. We have approximately 84 million people, and most of these people is living in urban area, and expected life duration is really very high, 84 women, for example. Hopefully, our people have health insurance. Majority of our population has any kind of health insurance, mainly by government, and it's cover every kind of treatment. And if you look at the world map, you can see our population. Turkey is similar to east part of Europe and north part of Asian region. And our death reason mainly consisting of cardiovascular disorders for men and women. And stroke is very important issue in Turkey as in Malaysia. Professor Basri has talked on this issue in very detailed form. And if you look at again world map, you can see Turkey here, again similar to east and northern part of Europe as population. And for our region, we have approximately 116% stroke death rate. And it's increasing with age. You can see our prevalence rate. It's increasing very strongly related to age. And there are some differences between regions. Interestingly, our Black region people have highest rate of stroke. And again, another study, this is an early study for the rates of hemorrhagic and ischemic stroke, and Professor Özdemir was the father of stroke, actually, stroke area. And I would like to offer my respect. You see, 71% is ischemic stroke, and a little bit higher than normal world population, 29% is hemorrhagic stroke. And risk factor for stroke, again, very important. And we have different rates for ischemic stroke risk factors. And this is lowest rate in northern western part because of lifestyle and eating habits, and Aegean region also because of good eating habits. Again, from previous study, you can see that hypertension is the more common risk factor for stroke. And we have some official numbers for risk factors. Hypertension is a cause for loss of daily 3.3%, and smoking again is very higher, obesity, hypercholesterolemia, and insufficient consumption of fruits, vegetables, and inactivity. Hypertension is again increasing with age. as everywhere, actually. You can see the prevalence of diabetes mellitus, and it's very common between 55 and 75 age. And we have a very high total cholesterol level, and this is more common among female patients, and triglycerides again. And obesity is very common, and its prevalent is more common in, again, among female patients, female people. Consumption of enough fruit and vegetables is not wanted level. And self-reported leisure time activity, again, is not enough. Smoking situation is decreasing, but not enough level. And alcohol consumption, not so big problem because of, religious causes, but again, still has an effect. And primary prevention is very important effort in Turkey, and with Health Ministry, we are conducting continuous online and face-to-face meetings and guidelines, and some online digital platforms and registries on primary health practitioners desktop. Stroke is very important issue again for us and for our ministry, and we have an agreement actually for this collaboration. And after announcement of this official documentation, we have many opportunity to care our stroke patients. Ischemic stroke new cases is approximately 100,000 in Turkey, and hemorrhagic stroke new cases is 40,000, and death from stroke is really very high, approximately 40,000. And you can see hospital situations. We have 85, we had actually 85 training hospital for neurointensive care units. And they have a lot of actually bed intensive care beds, and most majority of these hospitals have a CTU and MR facility, and it's increasing. And 22 centers, stroke centers run by neurologists, and more than 60% performed by neurologist interventionalists. This is very important. We are conducting again continuous education to increase this manpower in a neurointerventional area. And maybe you can remember that we have the first announcement of global stroke bill rights during the World Stroke Congress. IV TPA approval actually March by 2006. This is not in time, not in suitable time, actually 10 years later than EU. And estimated use in acute stroke is 3%, but we have not a national registry yet. We will have soon. And you can see some data from a meta-analysis, and if, our patients have mean good prognosis actually, approximately 60%, mortality rate is 16%, and intracerebral bleeding rate is approximately 6%. And we have many stroke centers and stroke units distributed in all region of Turkey. And another data, neurosolutive data, IV thrombolytic treatment frequency is 12%, and thrombectomy frequency is 8%. And we have many effort to increase awareness and information and knowledge on this area. Many schools, many academic conferences, symposiums, guidelines. Even during the COVID-19 pandemics, we continued to these efforts, and we had additional meetings and guidelines for COVID issue and stroke. And with ministry, we have common guidelines and stroke clinical protocol and quality stroke care algorithms. And we have established or formatted stroke care pathway. But we need to study more, and we need to increase all these opportunities for our stroke patients. For headache, we are again, we have some same rates as Europe, and we have some studies. Migraine is really very high in Turkey, especially among women, and approximate rates are 24, 25, 27 in some studies. And tension headaches and other headaches are common, and we have specific or special outpatient clinics for headaches in majority of universities. Multiple sclerosis is also another important disease group in Turkey. We have opportunity to cover all medication for MS, for every level actually. The prevalence of multiple sclerosis approximately 100 per 100,000 population. This can change, depends on region. You can see lower rates. And natural history of multiple sclerosis in Turkish patients. These are TÜİK official statistical data from government and by Kantarci and Siva. It's actually decreasing in ADC, and 50% will reach ADCC 6 at 18 years. But with new medication, this is changing actually. Estimated number of people with MS in Turkey, more than 40,000 actually, and they have first-line treatments, second-line treatments, and third-line treatments, according to their clinical features. And there are some familial cases. Actually, we have to increase awareness for familial forms. And Alzheimer's disease is another problem, and is getting increased because of increasing age. And 6,000 people died of Alzheimer's disease in 2011, but it's increasing. Parkinson's disease, another chronic degenerative disease, and we have 40% per 100,000 for female rate, and it's 55% for 100,000 for male, but they have any facility for treatment, including deep brain stimulation. Epilepsy, another young people disease, death rate is important again, and disability is more important. And with improvement of their some legal rights, like traffic driver licensing, they are more happy in this day. Yeah. And another, we had actually, as you, we had another risk and disease group with COVID-19 pandemics and with EAN, WFN, and other international organizations. Our society had a lot of effort to increase knowledge level for COVID-19 and neurological disorders. Cerebrovascular diseases and risk factors were the most influenced disease group, and dementia, Parkinson's disease, neuromuscular disorders, multiple sclerosis, epilepsy patients have been affected by this situation. And according to EAN survey, you can see all kind of neurological disorders during COVID-19. And we have also local data from Turkey. You can see again all kind of neurological disorders combined with COVID-19. And we hope that in the future we can have more options to prevent, to treat neurological disorders, and to increase our manpower in this area, and to increase our collaboration with our region and with other countries. Thank you very much.
Thank you, Professor Safina.
Yeah,
if you have any questions, you can email to Mr. Hasib.
Can I ask a question, Dr. Sharaf Noor?
Please, please.
Okay. Now, how many you have training facilities for outside doctors? For example, we are working on a project to train like doctors from Africa. Can they come to Turkey like for a short or long training?
Yeah, yeah.
They can go back.
If I understood correctly, we had 3 or 4 visitors, neurologists from Africa for the program WFN. With Africa was the name of this program, and they actually it was a very useful program for our visitors, for African young doctors, and for us also. We improved our relationship with these young colleagues, and it was really very wonderful times with them. We have 3,500 neurologists in Turkey, and it's increasing, but still not enough. In Africa, I don't imagine how they can manage all these neurological disorders, actually. So we would like to support them for every option. Thank you.
Are there any questions, Hasib, in the chat box?
No, there are no questions in the chat. So
okay. I have
maybe we should get concluding remarks from Dr. Salim and Hamidun for this session.
Okay, thank you. Assalamu alaikum. I'm first grateful to Professor Mohammad Iqbal Chaudhary and the whole team of comstech, one of the 4 standing committee of OIC, for arranging this first OIC International Conference on Neurosciences. As we know, the neurological disorders are increasing all over the world, and the number has even increased during current scenario of COVID-19. So the purpose of this event is to discuss and highlight the neurological disorders, the burden and challenges they are facing in OIC countries. So this first session was very informative, and the speakers talked about the different neurological disorders in their country. As we know, about 6 to 7% among all the neurological disorders worldwide have the neurological disorder are about 6 to 7%. And the stroke is the leading cause of the neurological disorder among all the diseases. The burden, the countries, as our speaker discussed, they have about burden of stroke, epilepsy, CNS infection, headache, motor neuron disease, dementia, Alzheimer's disease. So almost they all have this problem. The stroke was the leading cause of this burden among these countries. Challenges they have facing are the lack of effective healthcare problems and the lack of healthcare resources, deficits of EMR, technologists, and the lack of neurologists and the lack of neurology positions, low priority to the neurological disorders, and the lack of neurology positions at different level. The Malaysian and the Turkey, they have comparatively good health care system. These are the few challenges our countries are facing. And I will recommend a few suggestions at the end that we have more advanced stroke care services should be provided in the government setup. If most of the advanced care services are in only private centers in almost all the Islamic countries. So the government should also take care of this and should give the priority. And the cost of the technologies and the medicines should be reduced. This is again the problem in our countries. The cost of these medicines are very high. So no, especially it's not available in the government setup. So government should take this step. And the prevalence of the hypertension and diabetes are increasing, causing stroke and the mortality and morbidity. So different advocacy programs and the awareness program should be done through media to give awareness to the common public, especially in the rural areas of the different countries. And the neurology positions should be created at every level, not only the main large cities, but as well as in the small cities at the rural areas as well. So these are a few of my recommendations. And at the end, I'm thankful all the speakers, Dr. Rahman from Afghanistan, Professor Shehryar Nafisi from Iran, Professor Mohammad Wasif from Pakistan, Professor Hamidun Basri from Malaysia, and Professor Safina Ostok from Turkey. And I'm thankful to the organizers and all the attendees for attending this very informative session. Thank you all. And for the few coming from the chair of the session, Professor Hamidun Basri. Over to Professor Hamidun.
Thank you, Dr. Barik. Probably a short one from me. I think moving forward, we should all come together and have a discussion on what next, whether we want to continue on with this conference, and then what we can do to improve neurology in our region, the OIC Islamic countries, especially in terms of education, training of neurologists, and also probably research. So we are in a way quite close, and we can do a lot of things together. So hopefully this will come about, and I'm sure Prof. Wase will be leading this. So please be in contact with me with the AON side. So thank you so much, everyone, for listening to the talks. And I think we shall stop here, organizers, and we'll start again at 2:30 for the next second session. So thank you very much, everyone. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Shukran.
Shukran lillah.
So we'll connect at 2:30 again.
Yes. So we'll formally end the session 1. A quick thank you to our chair, Dr. Hamidun Basri, and co-chair, Dr. Salim Baraich, for moderating the session nicely, and to all the speakers as presented. So we'll move on to a break. We'll stay connected on the Zoom, so the same link will be used. And we'll reconnect at 2:30 sharp for our next lecture. So that's roughly 1 hour, 15 minutes to take. So let's get back here at 2:30 Pakistan Standard Time. Thank you all.
Thank you all.
Thank you.
Bye.
Dr. Maimuna Siddiqui, and I'm the neurologist and head of department Shifa International Hospital, Islamabad, and also president-elect Headache Society of Pakistan. So we have a very nice first session that we get to know the overview of neurological problems in the different countries, OIC countries. And we come to know, okay, what challenges we are all facing and what are the opportunities that lies ahead. So this session is basically more focused on the acute, on stroke care. As already discussed, stroke is one of the leading cause of disability worldwide, and the prevalence is more especially in the developing countries. This was mentioned in all the talks that were given in the first session. So to elaborate further on that, we start with this session. So our first speaker is Professor Fuad Abdullah. He's a professor of neurology and stroke medicine in Cairo University, Egypt. He is also the director of neurovascular unit and board director at World Stroke Organization for Middle East, North Africa, and the East Mediterranean region. And he's also the immediate past president of elect African Academy of Neurology. So the title of his talk is Stroke Care in Egypt. So we'll start with the talk.
Hello, everyone. I am Professor Fuad Abdullah, Professor of Neurology and Stroke Medicine at Cairo University, Cairo, Egypt. It is a real honor for me to introduce my presentation during the first OIC International Conference of Neuroscience. In my presentation, the first part, I will introduce the key features of stroke care unit in low resources countries. And in the second part in my presentation, I will show our experience from Egypt. This is my disclosure. First of all, I have to acknowledge Professor Peter Langhorn. He is a professor of stroke care at the University of Glasgow, and he is a joint coordinator editor of the Cochrane Stroke Group. He spent most of his career addressing issues related to stroke care and service in low and middle income countries. Thank you, Peter, for your effort. This is my agenda. First, we need to know what is a stroke care unit. A stroke care unit consists of a desk area of a hospital, takes care of a stroke patient Closure. First of all, I have to acknowledge Professor Peter Langhorn. He is a professor of stroke care at University of Glasgow, and he is a joint coordinator editor of the Cochrane Stroke Group.
Just give it a couple of minutes. I think there's a technical glitch. We'll just get it sorted, then play the lecture.
Hello, everyone. I am Professor Fouad Abdallah, Professor of Neurology and Stroke Medicine at Cairo University, Cairo, Egypt. It is a real honor for me to introduce my presentation during the first OIC International Conference of Neuroscience. In my presentation, in the first part, I will introduce the key features of stroke care unit in low resources countries. And in the second part in my presentation, I will show our experience from Egypt. This is my disclosure. First of all, I have to acknowledge Professor Peter Langhorn. He is a professor of stroke care at University of Glasgow, and he is a joint coordinator editor of the Cochrane Stroke Group. He spent most of his career addressing issues related to stroke care and service in low and middle income countries. Thank you, Peter, for your effort. This is my agenda. First, we need to know what is a stroke care unit. A stroke care unit consists of a desk area of a hospital, takes care of a stroke patient exclusively or near exclusively, and staffed by a specialist multidisciplinary team who work in a coordinated way through regular meeting plans and protocol. We need to know the difference between stroke center and stroke care unit. A stroke center is an integrated of care. It involves from the start the pre-hospital, the emergency people, and then the stroke unit with organized inpatient care, and finally the collaboration of the external department. But the stroke unit involves only the organized inpatient care in the world, and the stroke center is much more capacity than the stroke unit. What are the key components for stroke unit care? The key component for stroke unit care: board and staffing, management protocols, multidisciplinary coordinated team. So it is not the issue of the luxurious infrastructure. It is the issue of enthusiastic people and tailored protocol in place for young doctors to work with. This is the different disciplines in a stroke unit. The different disciplines in a stroke unit is a step-by-step management. Start from assessment and monitoring, medical diagnosis, nursing assessment, and treatment assessment. Then the first 5 days is the acute stroke management, managing the physiological parameters, managing complication, early mobilization, acute nursing care, then the multidisciplinary team rehabilitation, physical therapy, psychiatric assessment, speech, swallowing, psychological rehabilitation. What is the plan for discharge and secondary prevention? What is the benefit and the impact of stroke unit care? What is the evidence based for stroke care unit impact? This is the stroke unit trialist collaboration, which is the largest Cochrane database of systemic reviews in 2007. Comparing stroke unit care with an alternative service, I mean in general ward, it was found that more organized care was consistently associated with improved outcomes in a stroke unit care compared to the general ward. They did find the following: more patients discharged home independent, less admission to institutional care, and less mortality and fatality, which means a significant improvement in outcome compared to the control or general ward management. If we look to the stroke unit trialist study, it had been done in most of the units in the north of Europe, which is advanced technology, luxurious infrastructure, and some are in America, in the North America. And that's why it does not impact the low-income countries. We need evidence for importance of stroke care in low-income countries. So, the evidence for stroke unit studies in low and middle-income countries came from this meta-analysis in China, in India, in South America, in Africa, in East Europe, and the Middle East. It is clear that also the odd ratio for best outcome increasing with admission of stroke unit even in low resources countries. We need to know some lessons from the development of stroke unit care and its impact in low resources setting. If we look to this research question, does multidisciplinary stroke care improve outcome in a secondary level hospital in South Africa? We have the experience of Cape Town, one of the practical examples for stroke unit care comparing patient outcome before and after implementing multidisciplinary stroke care. Implementing multidisciplinary stroke care and comparing it before and after. So in terms of impaired mortality as an indicator of the overall quality of patient care. What did they find? They find significant reduction in the fatality and the mortality rate, much more improvement in the rehab facilities, and much more utilization of the hospital facilities for improving stroke patient care. What are the challenges to stroke unit development in low-income countries? We have the key feature, then we look to the challenge, and we look to the possible solution. First, we need multidisciplinary staff specialized in stroke, We need coordinated multidisciplinary team. We need training for the staff. A challenge, no enough trained staff, especially physiotherapy, occupational therapy, speech and language therapy. What shall we do? We train more nurses. We use the family and the caregiver. And we put a nurse-led protocol. It's not necessary to have a large number of physicians. You can train the nurse, you can train the caregiver. Then you need more beds at the hospital. So the challenge is difficulty to protect the beds. You can do a stroke unit base with flexible bed use. It is not necessary to be a discrete. It may be in different wards, but the team move to the stroke unit beds in different places. Management protocol, inadequate investigation and facilities. You can tailor and use the minimal required infrastructure. It is not necessary to have a luxurious infrastructure and to do a PET scan for every stroke patient. You can use your tailored protocol, your minimal protocol for stroke care, but you have to have a protocol. What is the discharge planning? We don't have enough rehab centers. We don't have enough speech therapists. So planning for post-discharge rehabilitation is a challenge. Train the families and the caregiver. These are the key features for the problem and the challenges and the possible solution. Summary 1. Organized inpatient stroke unit care is the most powerful, widely applicable stroke intervention. The basic model of stroke unit care does not depend on high technology facilities, but implement a systematic approach to care. Provides a focus for experience, service, development, and education. If you have a stroke unit, so you will develop all the service by default. Finally, I will give you our experience from Egypt and how research can it change and impact practice. We have to know that we cannot manage what we didn't measure. First, every nation should have a real epidemiological study about the stroke burden in their country or in their region. We reviewed all population-based studies in Egypt from 1992 up to 2013 to get a near real data about incidence and prevalence of stroke. We astonished to have a very high incidence rate of stroke, 200 for every 100,000. We have a very high prevalence rate, more than 600 per 100,000. Ischemic stroke was the largest proportion. Hemorrhagic is existing. Hypertension is the most known enemy for our stroke victims. Increasing with time from early 2000 up to 10 years, 2013, more than 10 years. The fatality rate is increasing. Then we have our cry, and we said that stroke burden in Egypt, current status and opportunities. We thought about the solution. We provided a roadmap for improved stroke care in low-income countries. We admitted that the first thing to do is the awareness and awareness. So we did a lot of awareness campaign. One of it is the Stroke Day, World Stroke Day, which is very important to gather people and to join forces for stroke awareness. One of the stroke days, we conducted a questionnaire for the people in different places in Egypt about the knowledge and awareness and the response of the general population to acute stroke. We did find that low public stroke awareness has been detected among Egyptians, and this was a call for the healthcare authorities to invest in public education program among the Egyptian population. Very low awareness about symptoms of stroke and how to deal during the acute stage and when to transfer the patient to hospital. What is the real thrombolysis? It was a problem. Then we conducted the Arabic version for the NIH stroke scale, because the NIH stroke scale is written in English, and if you want to make it easy for the young generations, for the nurses to use it in the acute stroke service, so you need your cross-culture adaptation of this English version. And we did that successfully and published it. One of our university hospitals in Cairo conducted this nice study showing the Egyptian experience how to increase the utilization of reperfusion therapy of thrombolysis in acute ischemic stroke. Actually, they did a survey before, and then they did the same survey after a particular kind of intervention. It is a prospective observational study to address the causes of low reperfusion rate conducted in one of the university hospitals from January 2015 and June 2015. It is a 6 months observational study. After identification of the main causes for low reperfusion rate, a corrective action was done and measured the impact of implementing specific measures to improve it. A proposal to the Egyptian Ministry of Health and the approval of the provision of the drug RTPA was given in April 2016 after this study. And a second prospective observational study was conducted for 6 months again, between January 2016 and June 2016, to detect the impact of this kind of corrective action plan. Here is the pre and in-hospital causes of delay, and as we see that the main problem of delayed presentation of the patient to the ER in the acute stroke setting is the awareness. And I mean awareness of the patient, relatives, and also of some of the general practitioners, some of the physicians. And the main causes of the in-hospital unavailability of the RTPE. And then beside the unavailability, the decision of the attending physician. Okay? So we need a corrective action for the awareness of the patient, primary physicians, and then we need in hospital to have the RTPA available off shelf and on shelf and free of charge for the patient under the medical insurance. Then we have an intensive training program for the attending physicians to do this. So what was the action plan used by this research group? Expansion of stroke unit beds, a structured protocol for reperfusion, a structured training program for reperfusion therapy, implementation of Arabic version of NIH stroke scale, a solid consensus to improve all the parameter indices of thrombolysis, senior audit and supervisor for the parameter indices, and finally, they called the Egyptian Ministry of Health for approval of the drug. This research group applied a very simple and clear protocol for reperfusion therapy that was used by all the junior staff for treatment of acute stroke patient.
Then, outcome of action plan. Increase in the number of admitted patients. Total number of eligible patients for acute treatment. Total number of patients who received the acute treatment is markedly increased. The percentage of total ischemic stroke patients who received acute reperfusion treatment is increased almost 5-folds. The percentage of eligible patients who received acute treatment is markedly increased. So, increasing the number eligible for thrombolysis. Increasing the number of patients who actually got the thrombolytic therapy. And also increasing the number of admission of acute strokes to the hospital as well. This is the outcome after a corrective action plan. We studied what are the obstacles for the pre-hospital delay and the in-hospital problems, and then a corrective action plan, and then we studied the outcome after that. Summary 2, we cannot manage what we didn't measure. You need epidemiological study for every nation about the burden of stroke in terms of incidence, prevalence, and fatality rate. So we need to know the stroke burden in our community. We need to know the real barriers. A comprehensive action plan should be involved in the form of health system, quality improvement, healthcare authorities. You have to contact the healthcare authorities. Government reimbursement of multiplace is a very critical step to successful implementation of any program. Don't forget now, tissue plasmination activator, essential drug for WHO medication list. Thank you so much, and I wish you all the best, my friends from Pakistan. Thank you.
Go ahead, Dr. Memuna.
Okay, so we don't have the speaker live here. Do we have any questions? I can't see. So it's a very comprehensive talk on the stroke care in Egypt. And the best part is that not only Dr. Professor Fawad mentioned the challenges and the barriers that we face, but also the solutions for that. So I mean, that is a very, that can be very helpful for all the other people who are planning to, start stroke unit care or improving their stroke care in their respective countries. So going through the burden and the challenges that you mentioned, I think most of the obstacles are the same that we also face here in Pakistan. What's your comment on that, Dr. Wasif?
Well, kind of most of the middle income countries in OIC area, they have same kind of issues. So Egypt and Pakistan are kind of middle income countries. So maybe we have Dr. Maria who is representing UAE. So we could have her thoughts on the stroke care in UAE, and Dr. Sohaila Lokan was unable to join. So maybe we could have her very close to the MENA Sino region. So we could also comment on that.
Okay.
Yes, Assalamualaikum.
Assalamualaikum. Good to see you, Maria.
Thank you. Dr. Vase continues to spring surprises on me. I just found out.
Thank you for joining. I know it's very, in the last hour you were called. So for everyone, Dr. Maria is consultant neurologist at Rashid Hospital, Dubai. UAE, and she's a graduate from AKU University, Arkan University, and then she did her vascular neurology fellowship from AKU and a master's in epidemiology, and currently working in as a neurologist and stroke specialist in Rashid Hospital, Dubai. So, Maria, what we were discussing that usually the barriers, the problems that Professor Fawad mentioned in his presentation that they face in stroke care in Egypt. I think the more or less the problems are same in other countries in the region also. Even we faces the same problem.
Yes, I quite agree that we have quite similar problems, and another problem that I've increasingly started to realize is that stroke care in the Middle East region, which now I am kind of familiar with, it's a very patchy coverage of stroke care. So you might end up seeing an excellent center established in a big city, which is doing very well, providing very good care, and they're maintaining all the prerequisites for a stroke center. And then you have areas where not even the basic stroke care is available. So I think that discrepancy, just like we put this discrimination between a high income and a low income country, that high income countries have all these facilities and low income countries are lacking. I think within the low and middle income countries, this gap exists as well. And so I'll speak about UAE. I'm sitting in Dubai. It's not a very big city. We have about 3 or 4 comprehensive stroke unit centers within the city itself. Okay. And the entire population of UAE is close to 10 million. Okay, and if you really stretch it, maybe half of that population resides in Dubai. But what about the rest? Similarly, Abu Dhabi is land-wise a huge area. Population-wise, it may not be so big. Abu Dhabi has at least 2 comprehensive stroke units. But if you come to the Northern Emirates, there's absolutely nothing there. There are 1 or 2 stroke centers that are providing, patchy sort of thrombolysis services now and again. And most of the patients who land up in those hospitals go without any sort of acute treatment. And then, of course, because there are no stroke neurologists or people who are sort of aligned, and you don't even have to be a stroke neurologist. If you're just aligned to taking care of stroke patients, then your approach is very different. So, the focus on rehab and the focus on secondary prevention, all of those aspects are ignored when, unfortunately, patients land up in areas where you're not, you don't have this sort of sensitivity to taking care of stroke patients. So I think one of the challenges within our countries, and I think the same is true for Pakistan also, with whatever, I'm still quite in touch with my colleagues back home. And I think that's our issue here. We have a lot of people in the big cities and a lot of setups in the big cities. But as you go further away, Sindh, for example, in interior Sindh, we are hoping to develop more centers there, and we are kind of engaging with people through various forums to develop neurologists and strokeologists in those areas. But I think these things continue to be a challenge, and that's something that's another thing that we can work on. A lot of times our focus ends with acute treatments, like is TPA available or not, is thrombectomy available or not. But I feel there's so much more to stroke care than just the acute service, right? How many patients, even in the best of centers, will be eligible for these acute therapies? If at best, maybe 20% at best. But what about the rest of the 80%? Are they getting optimal treatment or not? So yeah, that's my feeling on this issue.
So you are right. I mean, we faces the same problem here in Pakistan, that the treatment, the level of treatment is different across, even in the same city. I mean, if there's one hospital, big hospital that is providing stroke services, but then, there's none else. So, and what about the awareness issue? I think the first part was regarding public awareness. They work on improving the public awareness, and that, also leads to improve stroke care. So what's the situation there in UAE, like especially in those areas which do not have good stroke care?
Okay, so again, the awareness would again, it is a reflection of the stroke, interest in stroke and people who are willing to sort of be an advocate for stroke. And their presence matters. So wherever they're present, you see a lot of awareness campaigns happening. In Dubai, for example, we have, every year we have the stroke day being celebrated from the hospital itself. The awareness session would be here. We would have written for, newspapers, articles just to bring awareness to people in general. But I think that does not infiltrate to the wider masses, which is a real problem. I'm not Arabic speaking. So, I think language has a huge part to play. Dubai, of course, is a very sort of a multi-ethnic hub. But for the larger Middle East, I mean, Arabic seems to be the major language. And I think going forward, I'm sure a lot of work is being done, particularly in Egypt. I am in contact with some colleagues from there. But generally speaking, we don't see that kind of dissemination happening which should, and in that language. I feel what we need to move towards, particularly in middle income countries like we were talking about, is virtual health forums, which is the way to go. I mean, you can't reach out to people better than that. And I think if we really have to devise educating people, it needs to be through mobile technology, and in their local languages. That's the best way to sort of reach out to people. I don't think this is the period where we have conferences and public awareness campaigns. You can have public awareness campaigns, but I think we should use technology much more now, which is going to be much more far-reaching. But yeah, the awareness is lacking here, as it is in many other parts as well.
Yeah, actually, I was also coming on this point that what about telemedicine and I mean the telestroke concept that's very in place in Western world. So are you people thinking about establishing telestroke like a hub and spoke model? Because I think that is one
So you need to decide
option.
for these, absolutely. You need to decide where will this, how this this hub and spoke model is going to work best. So, for example, for Dubai, suggestions come for big cities only. Okay, so there was a suggestion that there should be a mobile ambulance, similar to what we've seen in Alberta. There were suggestions about this hub and spoke model. You can traverse the entire city of Dubai end to end in 45 minutes in the non-rush hour. Okay. Now, in a city like that, it is completely useless to make that kind of an investment. But you can make that kind of an investment if you want to bring people from other Emirates into Dubai, for example. Okay, I'm restricting my conversation only to where I practice, but you get my point. I mean, if we move towards those models, then we need to realize that it has to be done smartly. I mean, we don't have the luxury of a lot of finances, so we need to do this in a manner where we need to ensure first that the setups that we are doing are geographically, the catchment areas are not overlapping. So, for example, in Dubai, I think the catchment areas for the big stroke centers that we have are hugely overlapping. I mean, the entire city is our catchment area, right? And you have 3 setups within the same city. So it doesn't, I mean, from a stroke perspective, that's, I think, wastage. You're just dividing up the patients amongst 3 hospitals where only 1 hospital was sufficient, So I think going forward, if those models have to be adapted, they need to be very carefully designed, because we don't have a lot of money to waste on, poor planning but yeah, I think this is where we need to move, because we can't have a comprehensive unit everywhere. We need to move to places where we can establish a comprehensive unit and then liaise with other smaller units to sort of bring patients in if they require. But primary stroke centers, I don't think is a problem. I think a lot of people can be trained. We just need to be a little more brave about it. I feel they don't even need to be neurologists. I mean, if they're a physician, they can be trained to detect a stroke. I don't want an expert who can check reflexes. I just need somebody who can identify that this is an acute stroke, right? So I think we need to move to that, people, because there aren't enough neurologists around to sort of, so yeah,
I think
that's
we
my
have to
view on it.
follow a pragmatic approach. And true for our countries, I think the one thing that can make a difference is establishing primary stroke units. Either they are, led by a neurologist or even a stroke physician or any physician.
Absolutely, exactly.
Medical
Somebody who's
specialist
trained to give this
who knows how
medicine
to
should give
treat
it.
stroke. So I think that's the way forward, and we should work on it, because that has been shown that stroke unit care has definitely improves the outcomes, the mortality and the morbidity. So you talked about print media and the days and all those things. So how much you think the role of social media? I mean, it's like every person has access to Facebook and all these social platforms. So what's your take on that? If we
I think
create
we
public
need to use
awareness through
all these
this.
forums. Absolutely, we need to use all these forums. All those women who are particularly sitting at home in their 60s and 70s, the only thing they know how to operate in this day and age is Facebook. Okay, so we need to go to those forums. I mean, we don't need to be active on Instagram where only the younger crowd is. We need to be active on all the forums that the older crowd is active on as well. And I think, yes, that's a wonderful way to reach out to people. We just have to do it very smartly. It has the message has to be attractive enough that people can, and in their language. That's important. So yeah, I completely agree with you that we have to utilize these forums to disseminate knowledge both about primary and secondary prevention and about acute treatments.
I think there's a long way to go, but there's always, when there's a will, there's a way. And I think this conference will serve as a good, platform for more collaboration and learning from one another's issues. And thank you, Dr. Maria, again for this nice discussion and coming online in such a short notice. Thank you. Thanks a lot.
Okay, thank you.
Okay, so now we will move on to our next speaker. Our next speaker is Dr. Amal Hashmi. Dr. Amal Hashmi is the first female neurologist from Muscat, Oman.
We can't hear you, Dr. Memuna.
Okay. Okay. So now we move on to our next speaker. Our next speaker is Dr. Amal Hashmi. She is a leading neurologist in Muscat, Oman. She's the first Omani woman as an adult neurologist and the founder of the first stroke unit in Muscat, Oman. She is also the founder and the president of Oman Stroke Society. And the title of her talk is Stroke Care in Oman. So over to Dr. Amal.
Thank you, Dr. Maimuna, for your kind introduction. It's a great pleasure to be with you all. I'm very grateful for the organizing committee for giving me this opportunity to give this talk about the stroke care milestones development in Oman. So without further delays, I have nothing to disclose in relation to this talk, and in my talk I'll be covering and addressing the following points to give you an idea about where we are standing in Oman when it comes to stroke care. So first of all, I would like to introduce to you the map of my country, Oman. We're around 4.5 million only who lives in Oman.
We can't see your presentation, Dr. Amal. Please share the screen again. It's not sharing.
Okay, because I shared it. It seems to me that it is. So let's see. Do you see it now?
Yes.
Okay. I'm very sorry about that. Okay, so let's go back. So this is basically, so can you see my screens now?
Yes.
Okay, perfect. So this is basically the outline for the presentation that I'm going to be covering about the stroke milestones in Oman. We'll talk a little bit about stroke units, the national stroke protocols and guidelines, the stroke nurses training modules, and we'll reach to the future also plans in this regard. So first I have to tell you that actually Oman is a very diverse country, and we are only 4.5 million living in Oman. However, people and the population are actually very scattered through the 310,000 kilometers square. And currently, just to give you an idea, we have actually 4 stroke programs. And as the arrow indicate, these are the location of the stroke programs currently we have. And this is the distribution also in terms of the number of beds. So the largest stroke unit we have.
Your slides are not moving, Dr. Amal. Can you share again and put it on the slide share mode because they are stuck?
Oh, okay. All right. So let me stop it again and then, okay. Do you see my slides?
Yes, and put it slide share mode, full screen.
Yes, it is on full screen to me, but I'm not sure why it's not appearing as a full.
Not here.
Oh, okay. Share. And then slideshow, okay. So
yeah, put it on the slideshow.
So that's a slideshow to me. It's a slideshow, but it's not showing as a slideshow to your side?
Yeah, no.
No.
Oh.
Yeah, just go to
Can you move the slides?
Slides, just click the slides.
Yeah, I'm clicking on the slides. It's actually moving on my side, but
just next to 77%.
No, it's not moving here.
Not to us.
Oh,
can you click to like? Can you stop sharing and then reshare again?
Okay, this is what I did several times, but it seems like we're having problem. Okay, so let me share. Okay. So it's actually it's been shared now, and I'm trying to press on slideshow. Okay, and so now I'm pressing on slideshow, but you can't see the movement of the slides?
No.
No.
No, can you click like the slide number 4 and see if it comes on the screen? On the sidebar.
Okay, just a second.
Because the slides are not moving.
All right, I don't know. I don't understand what's the problem. I just had a presentation 2 days ago.
Well, that happens all the time.
On the same laptop, and I have no clue why it's actually not supporting them. So it's slides 4. So this is 4. So this is 4.
Yeah. Now this is, so by this way you can see now the slide.
Okay, so let's say if I don't share it as a slideshow, if I move to the second one, can you see it?
And now we can see.
Yes. Yes.
Okay, so I think let's keep it then on this way, because if we move to slideshow, it will not show. Can I just keep it on this mode?
This is okay. Yeah.
Okay.
Okay, I'm sorry, I apologize. So like I was explaining to you guys that currently we have 4 stroke programs, and these stroke programs are distributed from the north to the southern part of the country. And the largest stroke unit is located within the capital of Oman, which is Muscat, which we call it the central stroke unit with 11 beds. Then we have another one in Nizwa, which is around 100 kilometers away from Muscat with 6 beds. And then Sohar, which is 200 kilometers away from Muscat. And finally, we have Salala, 1 unit right in the south, which is around 1,000 kilometers away from Muscat. Now, the situation was before 2012, actually, we didn't have any stroke units or stroke programs in the country. Stroke patients used to be admitted in medical floors or sometimes scattered in other floors as well. And since then, we had 4. Definitely back then, before 2012, we did not have any internationally trained stroke nurses, nor locally or nationally trained stroke nurses. But since we started the training program in nurses, we were able to certify 3 nurses in collaboration with the Mainz University in Germany. And then we had this training nurses modules that was going on up until 2019. And unfortunately, we had to pause all the program during the COVID era. So currently we graduated up until 2019, we graduated 74 nurses, and currently we have corresponding stroke team and stroke multidisciplinary teams allocated per the stroke units and programs that I have just showed you. We do share one national stroke protocols for hyperacute and acute management of stroke, and this is being distributed uniformly through the country, so making sure that all patients will receive the similar treatment. And then we have one national stroke guideline, which actually not just include the acute and hyperacute, but it talks about primary, secondary prevention and include other subtypes of stroke like sinus thrombosis and also subarachnoid hemorrhage. The total number of intravenous thrombolysis we have achieved since we started our programs as actually 500 cases. This is as per the statistics of 2020, sorry. We still don't have the final statistics for 2021. We're working on it. Soon we could have the final number of cases. And we did up until 2020, we did around 60 mechanical thrombectomy. And if I'm gonna just share with you actually the data coming from our central unit, where the bulk of the cases that comes in terms for TPA for thrombolysis or thrombectomy. This is actually the distribution through the years from 2016 till 2020, and you can see that gradually the number of TPA is really in rise additionally for thrombectomy. And luckily, when we started, actually, we had only one interventionist, and now we had 3 of them within our central unit. So the situation is really improving with time. And if we divide this as per 2020, you're going to see, like I mentioned, the bulk and the majority of the cases actually coming from the central stroke unit, but we had around 99 cases for thrombolysis coming also from the other units around the country. Now, if we move further, this is basically to show you some of the pictures during this journey. So this was the announcement of the first stroke unit when it was started back in 2013. We had the official opening of the first stroke unit with 11 monitored beds. It's actually divided into 6 beds for male and 5 beds for females. Upon creation of this first stroke unit, we had the establishment of stroke code as well, in terms of the necessity for making sure that we get all the cases treated on the right time. And this is the subsequent follow-up of the stroke units opening in the different part of Oman. So in the next one was, which started to work, was the one in Nizwa Hospital, which is 100 kilometers away from Muscat, and established in, they started to serve stroke patients as of April 2016, with a total capacity of 6 beds, 3 for females and 3 for male. All the beds are monitored. And then the following one was Sohar Hospital Stroke Unit, which was started providing the care to stroke patient as of December 2017. And then we followed that by Salala, which is started providing the services as of June of 2018. And unfortunately, we were working on 2019 to establish another one. But because of the situation of the COVID, actually all the work being paused, and now we are kind of negotiating with the Ministry of Health to restart the different stages of this development. Like I mentioned, we have different hyperacute stroke protocols. This include management for hyperacute ischemic stroke, intracerebral hemorrhage, the management of MCA, the acute cerebellar stroke protocol, because it's a special situation when it comes to cerebellar infarcts or hemorrhage. And then we have the CVT and also subarachnoid. And so this protocol actually and the clinical pathway come in different pages, and you can actually follow the pages per your need in terms of navigating through the protocol itself. And then in 2013, actually, we established our first national stroke guideline. It was in collaboration with the Royal College of UK London, and this national guideline was actually approved also by our minister in that ceremony, where we had actually the first ever national stroke program. And then, of course, the journey had started, and it's yet to continue. However, it's currently pausing because of COVID. The training, which is extremely mandatory, and without training more and more nurses and more doctors to run such unit, we will not be capable of establishing more of these. And this is just to give you an example of the serial stroke teaching lectures and modules that we have started for the stroke general nurses that became eventually certified to serve as stroke nurses. Also, the training that goes also to the emergency staff to initiate always the mandatory to keep the door needle time within certain limits. And our door needle time has significantly improved with time, and the average door needle time for the year 2020 was actually 20 minutes. And then in terms of certified nurses, I talked to you a little bit briefly about that. Currently, we have 74 certified nurses nationally, and then we have 3 of them also certified in collaboration with the Mainz University in Germany. We always tend to have a lot of activities in the different sites and the different units that we have, and they are also a continuous, not only training and activities for education in terms of CME activity or celebration of the stroke days, but also constant meeting just to address all the challenges, which we consider it as an internal auditing between the 4 different programs. We also ran a very important training simulation programs for thrombolysis, and this is one of the examples that we did last, which was in 2019 in our emergency, where we do this constantly to actually shorten our door needle time. But again, it's quite unfortunate to pause those type of training, which was very stimulative, but actually every time we run it, our door needle time becomes shorter and shorter. And then, you know, if you keep doing these, I can grant you that door needle time would be shortened, but it needs to be in a sustainable way, because people tend to, you know, to hold back when they don't have much of training. And then additionally, we had a lot of international stroke conferences that we have run in collaboration with different speakers, key speakers, expert speakers from different part of the world. And I think also in the last one, which we had in 2019, we had Professor Wasi as a speaker with us, and we had the honor of his presence at the time. Definitely, we had a lot of also workshop and multiple exchange, like tele-stroke, for instance, which was something which was considered. And the minister, our Minister of Health, attended this tele-stroke actually workshop, because we wanted really to have the grant to establish a stroke, and maybe it would work the best in Oman because of the diversity and the scatter, because it might not be really cost effective to have stroke units in each and every province or wilayat as the national sort of distribution of these of the countries of the cities and villages in Oman. A lot of collaboration we had with the actually Germans specifically in the last few years, which again paused because of the current. And we have actually our minister signing with the German minister the memorandum of understanding for exchange of training in terms of nurses, and this was achieved in March 11, 2018, and we were about to send more of these nurses for training, but hopefully we can do that once this COVID era is over. We don't stop celebrating the Stroke Ward Day. Definitely, there will be a lot of activities run for patients at the time of that in terms of health education, but also a lot of CME activities and a lot of educational leaflets that can be distributed at the time. We ran a lot of also some of the campaigns nationally as well as within certain district, and this was the last one in 2019 that we had it as well. In terms of research, I think we started to build up a good number of research papers, and we published some of them since 2018. We've been a little bit more active in terms of research, and these are, I'm just sharing on the screen some of the actually papers that we have published in relation to the stroke. And then we moved into more international collaboration. We had also participated in one of the big studies does internationally, and like the global impact of COVID and stroke care and intravenous thrombolysis and decline in subarachnoid. And then also regionally within the MENA SINA organization, we had a few papers that came out that talks about the recommendation for the management of stroke patients in the Middle East in the COVID era. And I think Professor Wasi also was a co-author on these papers. And the last paper we have published is the lesson learned in stroke care during COVID-19 pandemic. And we had also the pleasure to have Professor Wasi with us in this paper. And we have few ongoing research paper that we are currently working on, the accreditation of stroke centers in the MENA region, MENA plus region, I would say, and then a few others that in the process of the analysis. We're hoping once this COVID-19 era is over is actually to expand in our stroke program locally. So we're aiming from 2020 to 2023 to have 3 more additional, because as I told you, we have already established some work and some training prior to the COVID-19 era. We had just 2 sort of push it further towards establishing some more. So we're aiming first to be rational. I think maybe it might take a little bit longer than 2023 because we don't know the situation with COVID. So I would write actually to expand it maybe to 2024 in order to be able to establish additional 3 stroke units in other districts. And then maybe from 2000, I'm sorry for the mistake, it was supposed to be for the other additional from 2024 in other part of Oman. So let's give you an idea about what we are actually planning. So the initial 4 stroke programs is the one in Muscat, in Suhar, in Nizwa, and Salala, and we are trying. The next on the pipeline to be established is the one in Sur and one in Ibra, north and south Al-Sharqiyya, and then the south Al-Batana. So these are the one in purple are the one in the pipeline to start it soon. And then once we actually handle those, maybe we could start the 2 additional in Masandam, which is right the top north of Oman, and then the Al Burimi, which is a close border with United Arab Emirates and Saudi Arabia. So we're aiming to establish a total of 64 beds actually by 2026. If things moved smoothly and we did not have any obstacles regarding to COVID, and sometimes I'm sure also there will be some challenging that we're gonna face in terms of budgeting for this stroke, and maybe we could also initiate the telestroke, which I think it would work perfectly for Oman. For instance, this part of the country, there are very few scattered inhabitants that lives in here, and also that people that lives in this area. So I don't think it's really cost effective to sort of start an independent stroke programs on this, but we can probably, with the help of telestroke, we could actually provide the care for patients who lives in this area through telestroke. So this is basically all I have to say. I think the road is still long and we still need to achieve more and more. This is, I think, just the start, but the work in stroke is very challenging because of the nature and the dynamic of stroke and the requirement for also the multidisciplinary care that is specifically you need in terms of treating stroke patients. But with the collaboration, if we all could collaborate in the region, we could probably achieve better goals because we can be then united, and maybe we can distribute the task force in terms of what each and every country should focus on, and then that particular country should be the one that we should target and aim in terms of whether train nurses programs or training programs or fellowship programs, like I heard Professor Wasi was talking this morning as well. So this is all I have to say, and I would again thank you for giving me this opportunity to present that, and I apologize for my slide that did not refuse actually to go on a slideshow to be more appealing to you. So that's all I have to say. So thank you very much.
Thank you, Dr. Amal, for a very nice and comprehensive talk. And yes, you rightly said, when there's a will, there's a way. And I think if we collaborate with each other, and then we can, improve the stroke care, not only in our countries, but in the whole region. So thank you again.
Can I ask a question, Dr. Memuna?
Yes, sir.
Okay. Now, Dr. Amal, you have started a very good training program for the nurses.
Yes.
I think that I was very impressed with the program. Is it possible that you could put that program on like the YouTube or a social media channel, something like that? So that could be useful for all the other parts of the countries, and maybe like online hands-on teaching. I think that was very good, and especially for the nurses and the ambulance personnel and those kind of things. So How could we learn from those experiences from yours?
Yes, Professor Wasi, thank you very much for bringing this to the attention. Yeah, I think we can do that. Actually, my plan was once we wrap up the accreditation things, we could actually post those training module on our Mina Sino website. And so it can be accessible for other countries also if they would like to use it, or even use it with some modification that would best fit their own needs and requirement. I think it would be a great thing. So definitely this is something that I'm looking forward to do, especially if we're going to go ahead with the stroke unit certification and accreditation that we are hoping to kick as soon as this COVID-19 is over. You would definitely, one of the criteria for getting this accreditation for centers is having a proper training and enough nurses being trained to deliver the service to the stroke patients. So yes, absolutely, I'm open to the idea, and I have no problem in sharing that for the benefit of all stroke patients and all stroke programs in the region. It would be a great pleasure.
Okay, thank you, Dr. Amal.
Thank you, Dr. Maimuna. It was really nice seeing you.
Okay, same here. So if there are no any other questions, we can move to our next speaker. So our next speaker,
Maimuna?
Yes.
Do you have access to your email? I have just sent you an updated brief for Dr. Johanna.
Okay. Yeah. So our next speaker is Dr. Johanna Kasoma. And Dr. Johanna is currently working as a consultant neurologist and head of hyperacute stroke and neuroscience service, and honorary lecturer at National Brain Center Hospital, Erlangga University, Jakarta, Indonesia. And he will be talking about stroke care in Indonesia. So welcome, Dr. Johanna.
We can't hear you, Johanna.
Dr. Johanna, you have to unmute yourself.
Okay.
You know, that's all right. Yeah.
Oh, sorry. Can you hear me now?
Yeah, yeah.
Okay. I would like to thank you, Dr. Maimuna, as a chairperson, and also to you, Prof. Wase, who invited me to this symposium. So thank you for giving me a chance to present stroke in Indonesia. For this presentation, nothing to disclose. Stroke burden Indonesia. At this stage, we have incremental in terms of the stroke disease in Indonesia. It was about 7.1 thousand residents diagnosed with stroke in 2013, and now become 11 per 100,000 residents. Stroke mortality is very high in Indonesia, so that's why stroke is the #1 cause of death in Indonesia, aside from mortality, aside from disability too. And for the disability rate, it reaches about 65%, and it causes a high stroke economic burden in Indonesia. Although heart disease contain about 52% in terms of the stroke economic burden, causing the government need to pay for the stroke, the healthcare in Indonesia. And number 2 is cancer. About 7% 10% and stroke about 12% in Indonesia. The challenge stroke in Indonesia, the first thing is the time. Why? Because the time to do referral usually more than 30 minutes in Indonesia. And then the stroke onset when arrive in the hospital usually more than 60 minutes. So it costs door to needle time also more than 60 minutes. For the human resources, a limited neurologist number, in particular, who has ability to stand by 24 hours in the hospital. And the nurses sometimes not always well trained for the stroke services skill. And then for admission time, sometimes also delay due to administration processes. For the stroke management guideline, we already have it for the stroke national guideline, which has just been approved in July 2019, and still needs some times to notify to the neurologists all over Indonesia, because we have a lot of island in Indonesia, and sometimes difficult to be accessed. And for the facility in Indonesia, sometimes we have a limited CT scanner, and there's only transfer ambulance, but not stroke-ready mobile systems. And patient family need to figure it out by themselves to refer the patient or their own family who developed stroke to the hospital in Indonesia. Limited stroke centers or stroke-ready hospital. Limited hospital with stroke dedicated bed. And for the national health insurance, they don't cover all acute stroke treatment, especially thrombectomy. They don't cover thrombectomy, and for alteplase, they only cover for 1 bottles, because usually we need 2 bottles, but government only cover for 1 bottles. But in our hospital is the referral center in Indonesia. So we use as a represent a hospital in Indonesia, but we do have a significant improvement in terms of reperfusion therapy. So started since 2016 up to 2020. So we have a significantly increased number for RTPA from 12 RTPA, and then now we already reached 207 in 2020. So the key success to improve the rate of reperfusion therapy are, we do have integrated multidisciplinary stroke teams from neurologists, neurointerventionists, emergency doctor, radiologists, triads, nurse, laboratory, and pharmacists. We do regular training to ensure all the stroke team members are well trained. We do disease awareness campaign in terms of to increase the public awareness on how to recognize stroke symptoms and come to our hospital within the golden period. And we also collaborate with the third-party public relation to campaign disease awareness. Sometimes we collaborate with the pharmaceutical to provide symposium or public symposium. And also we educate the local women representative in surrounding area, because many stroke also occurs in women, and then also easily if we educate the women surround us to recognize the sign and symptoms of stroke. And we do have a significantly reduced door-to-needle time in our hospital. So as you can see, from 2017 up to 2020, the door-to-needle time reduced from 105 minutes become 58 minutes. And the 4 key actions to reduce door-to-needle time are, we provide our neurologists on site 24 hours in the emergency room. So our doctor consultants also on site in our National Brain Center. And we do direct to CT scanner by simplifying the admission process. And we do provide the CT provision by using rapid software and CT angiography. And the result will be sent directly to our emails. We do not wait to complete the blood test result unless thrombocyte count, INR for those who use anticoagulant. And we give a bolus intravenous thrombolysis at the CT room if there are no contraindication applied. And here the trend number of stroke inpatient cases in National Brain Center Hospital gradually increased since 2016 up to 2020. So from about 1,000 and now we reached about 4,068. So per year we handled about 3,000 stroke patients in our hospital. So significantly reduced percentage in case fatality rate of stroke inpatient cases in National Brain Center. So from 2016 up to 2020, the case fatality rate increased from 16% to 12% for hemorrhagic case. For ischemic stroke, reduced from 6%, now become 4%. The distribution of stroke onset time in National Brain Center Hospital 2020. The stroke is for ischemic stroke for golden hours less than 4.5 hours, about 28%, but more stroke patients still come more than 4.5 hours, still 72%. And for the stroke severity, mostly they came to our hospital for ischemic stroke about moderate for stroke severity, and for the hemorrhagic stroke, also moderate. But for ischemic stroke, predominantly mild, and for hemorrhagic stroke, still moderate. And for imaging performed in acute stroke patient, we do CT, non-conscious CT brain or MRI. But in Indonesia, overall, 95.9%. For acute stroke patient, they will perform non-contact CT brain, and in our hospital, increase about 96.23 to 3%. And in 2020, in Indonesia, overall 97.49%. In our hospital, increase about 99%. So that means all the patient we will perform CT, at least non-contact CT scan. But within 1 hour in our hospital also increase from 94% become 96% in 2019. In 2020, a bit reduced, become 88%. This is because of COVID-19. And the percentage rehabilitation assessment in stroke patient, we always perform rehabilitation after the patient about to discharge or in between admission. So in 2019 and 2020, actually a bit similar, 99% in our hospital, even though in Indonesia, 98%. Like I said, we always do physiotherapy for our stroke patients. For stroke unit in our brain center and in Indonesia, we always put acute stroke patient about 55% of cases, but especially those who receive IV thrombolysis, we will put into stroke unit. But in 2020, we have reduced the number of IV thrombolysis. This is because of COVID-19, and we need to perform a COVID-19 protocol as well. So this is the acute stroke pathway in National Blood Center, which we always use. For onset less than 4.5 hours, we always do complete CT brain, CT perfusion, and CT angio. And then if confirmed ischemic, we will do RTPA. If there is no large arterial occlusion, we will proceed IV thrombolysis. But if there is large occlusion, we will perform either both or straight, either both. So that means RTPA and thrombolysis, endovascular clot retrieval. But if, let's say, there is no large occlusion, so that means only RTPA. As well as for onset 4.5 hour up to 24 hours, we don't do RTPA for those patients, but we still perform endovascular clot retrieval if needed, if let's say there is a large occlusion disease. And also apply for posterior circulation of vertebral basilar artery. This is overview achievement in National Blood Center. So since 2018, because we perform acute stroke pathway, and we also collaborate with Angels or rescue, and then we perform rescue in Indonesia too. So in 2019, we got gold award in National Blood Center because of our stroke services, and also platinum. And recently, in 2021, we've got diamond award for our stroke care services in National Blood Center. So that means our National Blood Center also already become like a example hospital ready for acute stroke ischemic center. I would like to acknowledge our national neurovascular team in National Blood Center Jakarta, Indonesia, Rescue Angel Boehringer Ingelheim, and National Blood Center Hospital Data. And then I would like to thank to my principal, co-principal investigator, Dr. Mushid Bustami, and verificator regional, Dr. Adin Nur Hasana. Thank you very much.
Okay, thank you, Dr. Yahana, for a nice and elaborative talk on the stroke care and the level of stroke services in Indonesia. And I think it's very commendable that you got so much applause and you achieved that awards. So are there any questions?
Now, most of the data, Johanna, is coming from Jakarta. How is the situation outside Jakarta, especially in other parts of Indonesia? Indonesia is a very big country.
Yeah, because actually we still gather all the data. We still gather all the data from rescue, but a bit difficult for them to do thrombolysis because of lack of the imaging, especially for CT brain. But actually at the moment they are trying to develop thrombolysis. So that's why we also collaborate to become a pilot hospital for other hospital in regional Indonesia.
But you are doing like tele training or tele consultation or tele thrombolytic therapy in different parts of Indonesia?
Yeah, actually we still do a workshop for thrombolysis. we still do it. We're still doing it. We are doing it at the moment. And then maybe, and especially during COVID-19, also a bit difficult because, you know, the protocol COVID-19 also quite strict. And then especially during Omicron time, this is really increased, and then we really have a difficulty to do thrombolysis, to be honest.
Okay.
Yeah, but we still working with rescue to gather all the data. But we still try to work with other hospital to be ready for acute stroke care system in their hospital.
Okay, thank you.
Yep.
Okay, thank you, Dr. Joanna, for such a nice talk.
Thank you.
With that, we move on to our next speaker. Our next speaker is Dr. Hussam Al-Jehani. He's the assistant professor and consultant neurosurgeon. And he's also consultant interventional neuroradiologist and neurocritical care and head of the neurovascular program at King Faisal Hospital University. And he will be talking about stroke care in Saudi Arabia. So welcome, Dr. Sam.
Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. Thank you very much for the invitation to participate in this wonderful event, which is commendable given all the difficulties, and I hope we meet in person in the near future. So I'll talk about the stroke burden in Saudi Arabia. I'll go through the journey that we passed over the last decade or so, focusing mostly on our region in the Eastern Province. I have nothing to disclose related directly to this talk. I always start my presentations by honoring our mentors that we learned from, and we only do them their due respect if we advance beyond them. So I live in the Eastern Province of Saudi Arabia, and it's like one of the major provinces in the country size-wise, and population is 4.5 million. We are located in the center of it, although the lower half is probably desert, but still we are in the middle of the region. Our neurovascular service, or neurointerventional service as we renamed it recently, is a multidisciplinary unit. We have people from neurosurgery, radiology, and neurology, and we work together and cover all cases all year long. It was formally established in 2016. This is our team. We have neurointervention, we have vascular neurology, we have neurocritical care, and we don't forget our techs and nurses. We are quite busy, and we achieved diamond status from the Angels program. And we have a hybrid room that was installed last year, and we are doing hybrid cases on a regular basis in that room. This is why we are here. We want to prevent brain damage, and this was like a slide from the 60s, where you can see that people with stroke, they do have a lumbar puncture. If it's bloody, they go as a subarachnoid hemorrhage, and if it's clear, it's like a seizure. If it's cloudy, then it's meningitis. And we came a long way from there, and we have a much better understanding of where we are. So I will talk briefly about the challenges that we had in a special peculiar encounter with intracranial atherosclerotic disease, and the advances that we're having in post-stroke rehab and the rehab potential in our region. So we all know the alteplase competition, and it's making its way to our practice, but it's limited by short supply. It's very helpful when we're talking about telestroke or transferring patient from the hospitals in the network. It's much easier to deal with, and that will facilitate timely thrombolysis. The interventional access is standard femoral or radial access, series of catheters to get to the intracranial circulation guided by wire navigation. I don't know if it's fortunate or unfortunate, but fortunately I worked with this first generation thrombectomy devices. They were very harmful and rigid, but we evolved and went into stent retrievers. Now we have a plethora of stent retriever devices with different shapes and different geometries, reflecting our understanding of the clots that we encounter. And we can combine the techniques so they can be more effective, and we go for the ADAPT technique, which is the aspiration catheters, and this cuts the procedure time in half. You can do an aspiration in 4 minutes, but you can do the thrombectomy like 30 minutes with the same result. To do an intervention in Saudi Arabia, sometimes we feel like superheroes, but sometimes we really get crushed to the ground. Because it's still, there's a lag behind when it comes to physician awareness, and population awareness as well. So here we have major risk factors that diabetes, hypertension together, diabetes alone or hypertension alone, smoking, especially in younger patients, and age, that we're encountering younger and younger patients as we are evolving in our practice. And you can see that the number of, there is a still big chunk of patients that harbor 1 or 2 or even 3 risk factors altogether. So we have a lot of work to do with our family physician colleagues and public education. We did our own sample in our region, and we found that the community, they have about 40% identification of the fast. And to our surprise, some of the family physicians and interns and emergency physicians, they did not get it right as well. So it is a problem that some of the first encounters are by some people who don't know. So this led to a region-wide campaign for education, and we used radio ads and pamphlets distributed in malls and stuff like that, so to improve the awareness of the population. The incidence is not terribly higher than the rest of the world, but it varies by region. So when you look at the Eastern province, again, I mentioned Riyadh province is 14% of all strokes reported in Saudi Arabia, and that population is 9.5 million. Our Eastern province is 20%, and it's 4.5 million catchment area. So we are having relatively more strokes than the rest of the country. And it is important to realize that when we come to planning and distribution of resources as well. So here, as I just skip this for, we're talking about 2,500 cases per year, and we're expecting this to increase. But we're still lagging behind when it comes to thrombectomies performed for multiple reasons. So we'll allude to in the next few slides. So here we have in extended time windows, but still it's a problem for getting the patients to our hospital or to the thrombectomy centers. So where is the disconnection? It's that I'm just skipping this because of the time, and I see that we're kind of behind, so we'll just skip a few of these. So here, this is the standard that is applied in the world: comprehensive stroke center, primary stroke center, and acute stroke ready center, and basic care. Now we are more geared towards thrombectomy center, so where the patient will get the thrombectomy and either go back to their referral hospital or make their way to the comprehensive stroke center, depending on the pathway and the region. So here, as I said, 40% of our population don't know the fast. 80% of the patients arrive by family, not by ambulance, and we suffer from the consent deniability. So the family will decline the thrombectomy for the patients, and the sector divide, meaning that we have university health system, we have Ministry of Health system, we have military, National Guard, and private. They don't talk to each other, and the referral is kind of problematic. So developing a hub and spoke model might be challenging because of the large area and the sector divide, and it's usually email based and with a poor perception of the time sensitive nature of stroke. So there is no perfect model anywhere in the country or in the world. We have to work with limited accessibility, limited personnel and resources, and the traffic nightmare, because if you see, this is one area There's one traffic in daytime and it's nighttime. So, and this is weekend drives to thrombectomies. I mean, it certainly have an effect on our coronaries, and it shortens our lifespan. So we have so the policy and procedure constrained in the hospital, the team availability, and we really faced a lot of challenges during COVID with protection and PPEs and stuff like that. So we have to be aware and improve our practices constantly. But we aim for either drip and ship or drip and keep model. The other challenge that creates a problem for the inflow and outflow of patients is the length of stay, because we don't have dedicated rehab centers. So the patients will most likely stay for the big initial phase of their rehabilitation, and length of stay is averaged at 45 days. So we need to work on that and improve our practice. So in the Eastern Province, as I said, we developed a story kind of in the last decade or so, where we complemented each other and we tried to break the barriers. So we started with the mothership in 2015, drip and ship in 2016, drip and drive. So we started going to the places where there is an angiogram, and we do the thrombectomy there in 2017. But because, again, logistical restraints, we developed the model that is called thrombectomy and back. So we get the patient to our hospital, do the thrombectomy, send them back to their neurologist to take care of them. And lately, we're doing the drive and retrieve model as well. So we have the drive, like this last arrow you can see is about an hour and a half drive. So the minute we get the alert, we start driving, and they have material in their hospital where we can do the thrombectomy safely. This is a publication about our thrombectomy and back model, where there is no hospital stay at all in our hospital. That way we avoid the burden of occupying our beds in an unjustified manner. Still, there are some doubters for the thrombectomy, whether it's the age or the relocation. Distal occlusions are still a big debate. Posterior circulation is a big debate. So we have to keep up, and we have to update our knowledge collectively. Sometimes with the failure of thrombectomy or beyond the window thrombectomy, we still have some work that we can offer in neurocritical care, thanks to our colleagues from the neurocritical care team in the ICU. So we work with melanone as an agent to augment the collateral circulation and mitigate some of the damage that might happen from an ischemic insult, and we're having promising results with that. The ICAD is a story that kind of elusive in the Western world, but we face it a lot in our region, and it is perceived to be 5 to 10% of stroke, but we will see soon that this is not the case in our region. The traditional risk factors are the same, with a few exceptions for certain genes and inhibitors and stuff. So I will just not go into the details of the imaging, because you're all aware of that. MRA and CTA and DSA and TCD, and all of this is where we can collectively image and follow up the patients. Dr. Al-Khatami and his group from the National Guard network in Riyadh and Jeddah, they found that they encountered 13% of their TIA patients and stroke to have ICAD. Dr. Azra Zafar and the vascular neurology group in our hospital conducted a comprehensive review of our cases and found 31% of all strokes and the distributions are in different vessels and watershed zone and non-watershed zone, perforated territory, and so on. So it's still a real practice problem. And we can offer angioplasty alone, or angioplasty and stenting, or indirect bypass, and we're talking about ischemic preconditioning now. So this is an example where angioplasty alone worked. Here we had to put a stent, although the stent was really suboptimal in the belly of the stent, but still the forward flow was improved significantly. We do face from time to time moya moya patients or moya moya-like patient in our region because of the high prevalence of sickle cell disease and thalassemia. So this is a patient who, as you can see, had a significant distal ICA stenosis and area of poor supply in the right hemisphere that is circled there. So we did indirect galeal transposition, and that will provide good source for their circulation. We do this systemically. Ischemic preconditioning is something that we are starting to learn because of this kind of problem that we have in some of our patients. Stroke behavior, if I ask you which patient will be doing worse, you will definitely point to the one on the right side because of the smaller stroke. But when we do the functional MRI, we see that the patients are having that patient on the right is having bilateral activation to hand movement. That means that this is more of an inhibitory pattern than a stimulatory pattern, and this is reflected on the corticospinal tract. And this will improve our understanding of rehab and rehab potential in patients. So we are starting to work with electrical stimulation for our patients. So whether it's transcranial magnetic stimulation or direct current stimulation for stroke patients to enhance the physiotherapy of our patients and enhance their recovery and shorten the recovery in a systematic and objective manner. Our colleague, Dr. Faisal Abbas, is working more and more in functional restoration with functional neurosurgery. He's one of the vascular team who's kind of adding this service to our unit and working with motor cortex stimulation to enhance recovery. And we can see that from the results of the trial, actually the hand area expanded from 16 millimeter to 27 millimeter after 3 months. So it is a promising tool. And the last but not least debate is to go directly to the angio or not. Still, we have a lot of logistical challenges, and the science behind it is still evolving, and we have a lot of debate about it. But I think the younger the patients, the shorter the times, going straight to the angio is the way to go. So in conclusion, acute ischemic stroke is still a major health issue in Saudi Arabia. Systems can advance in each area individually, looking for geographic and logistical constraint. You cannot have one size fit all solution. And the advances to improve the stroke journey from hyperacute pathway to rehabilitation. And to do that, we have to establish a network vision. We cannot work alone. And we see the gaps and needs, and we work with small steps and collaborate effectively and engage in local and international registries and trials, because our patients deserve better. And hopefully one day we will find ourselves in a situation like this in the Eastern Province and in different regions in the country. And again, I thank all the team members that work really hard with us, and our families for putting up with our sacrifices and their sacrifices too. Thank you very much. And our neuroanesthesia, there cannot be super emphasized. They're behind the scene, but they always make what we do safe, and it's a pleasure to work with them. Thank you very much.
Thank you, Dr. Hassan, for such a nice and excellent talk. And I think we should also, focus that you mentioned in the last that post-stroke care is really important and rehabilitation is very important. So do we have any questions? So the one question that was in chat was the difference in the rate of strokes in different regions of Saudi Arabia. Any explanation for that?
Well, some of it is underreporting, especially in the small areas. But if we look at the well-established 3 major areas in Saudi Arabia, or 4 major areas in Saudi Arabia, these are well established in terms of reporting. So there is a variation that is attributable to either a genetic or environmental factor. And And we're looking into that because, as I alluded to, there is higher prevalence of sickle cell disease in certain areas of the country. One of it being the Eastern Province. So maybe that's one of the reasons why there is a higher prevalence of stroke in the Eastern Province. But still, we have to study this systemically, and we are doing that at the moment.
Can I ask a question, Dr. Maimuna?
Yes, sir.
Hossam, do we have a national stroke registry in Saudi Arabia? Because it's so big and it's like widespread across so many regions. So is there like a national data for patients who got thrombectomy, thrombolysis versus no thrombolytic therapy? What's the status?
Yeah. Thank you for this excellent question. Actually, Dr. Ali Al-Khatami is the one leading the national registry, and it's under the umbrella of the Saudi Health Council. They started in Riyadh area because it's the largest with the largest population, and they're rolling it out to different regions one by one. The problem being the COVID, it actually came and halted everything, and because of the restriction of hospitals, and it was felt that it's not appropriate to continue the registry while hospitals are shut down and transfers are blocked. So it will come, but at least in Riyadh region, there is a registry ongoing. I see a question in the chat about the rehabilitation. I agree that rehabilitation is something that is dedicated in centers, but the physiotherapy has to start immediately after the stroke. So what we say, the patient passes the 36 hours or 48 hours, 72 hours, and even in the ICU, we still start the physiotherapy on them, and when they go to the ward, we continue. So the earlier, the better.
So are there any other questions?
I think those were the only questions in the chat.
Okay.
Thank you very much.
So thank you, Dr. Hassan.
Thank you.
So now with this, we move to our next speaker. He's Professor Dr. Atilla Özkan Özdemir. He's the Vice President of Turkish Cerebrovascular Disease Society, and he's the Chief of Eshker Osman Gazi University, Faculty of Medicine, Department of Neurology, Turkey. And he will be talking about stroke care in Turkey.
Thank you for the invitation. Thanks for this great meeting, Dr. Siddiqui and Mohammed Wasai, for his invitation. I'm sharing my screen right now. So I think there is no problem in the system. So
yeah, it's working all right.
Yeah.
Okay. Thanks to everybody, and it's my great honor to present in this great meeting, and please convey my best regards to all Pakistani colleagues. I'm talking about the Turkish Cerebrovascular on behalf of Turkish Cerebrovascular Disease Society. We are a part of World Stroke Organization and European Stroke Organization as a Turkish Cerebrovascular Disease Society, and we are the part of also MENASIN organization. So we are a kind of bridge from Europe to Asian and Middle East part. So we are also the part of SAFE, the Stroke Patient Voice for Europe. So we have been collaborating with MENASIN organization, with the MENASINO colleagues. Thanks Osama, and I've just seen Hossam, and thanks for their help. And we are also we have some endorsed meetings, like legal meetings with Society of Interventional Neurology. They support us in our Stroke Academy meetings. So we have a 85 million population, and 1% of the total world population. 76% population is urban, mostly living in the cities, and the life expectancy is quite higher when you're comparing with 10 years ago. So we are aging, The atrial fibrillation incidence is higher, and also stroke incidence is higher. It's coming to 200,000 cases as an incidence. And ischemic stroke incidence is higher than hemorrhagic stroke for sure. In the 9th World Stroke Congress, as you know, Mr. Clean was presented in Istanbul. So this is the first step for the mechanical thrombectomy. So IVTPA was approved in 2006, 10 years later than United Union. And so we have a study of thrombolysis in series of thrombolysis in Turkey, and we have the same amount of prognosis comparing with randomized trials. We have also kind of studies looking for the percentage of patients who received thrombolysis and thrombectomy. There are variations according to the regions. So we have some problems implementing the stroke care regarding the regional support. So the thrombectomy rate is increasing. This is the most important thing that happened in Turkey. The Minister of Health actually declared a stroke care program that was actually has happened in 2019, and they certified stroke centers, both primary and comprehensive stroke centers, regarding to that. So as you're comparing with 2017, 2021, more than 1,000 stroke thrombectomies were done, and we have a program that was actually organized by Turkish Cerebrovascular Disease Society and Turkish Neurological Society, a fellowship program that trains neurologists for neurointervention, especially for stroke thrombectomies. And this increased the number of thrombectomies and the centers. We have our own stroke guideline and stroke clinical protocol that has been collaborated with Ministry of Health. Right now, we have we do have IV thrombolysis handbooks, a scholarship for TPA training, and scholarship for intervention neurology training. That was held by Turkish Neurological Society and Turkish Cerebrovascular Disease Society, with regular meetings that was organized by Turkish Cerebrovascular Disease Society, and we'll be happy to share our knowledge and collaborate with Pakistani Stroke Society with these meetings. We do have several Turkish working groups under Turkish Neurological Society, and we do have a Turkish Cerebrovascular Disease Society dealing with stroke. And we have our website, Turkish Cerebrovascular Disease Society website, that you can easily go, and it's both in Turkish and English. We do have several activities there. In the COVID-19 period, we did publish our own expert opinion in the Turkish Journal of Cerebrovascular Disease, and it's open to everyone, and we'll be happy to collaborate with you. And as a society, we also have a pilot project implementation of 911 system and mobile application, and we have finished it and give it to Ministry of Health for a pilot project. This is a kind of application program for a 911 system and a mobile application program. In 2017, the thrombectomy, availability of thrombectomy is very less. However, right now, it's the thrombectomy ready centers are increasing, and we train every year a stroke neurologist for interventional neurology. These are the centers, and we are growing up. And these are our certification program for interventional neurology fellowship program. And these are all documented practical case reports. and we train neurologists and with the knowledge of vascular neurology and neurocritical care and neurointerventionalists. Still, we do have a lack of neurointerventionalists in Turkey. Here are our activities for training in interventional neurology. And this is our public campaign. We are collaborating with an University of Education and Communication for the public campaign. This is a short film competition for public campaign of stroke awareness that was organized by our society. This is another campaign. This is the 911 system and about the symptoms of stroke in Turkish. These are all our website of Turkish Cerebrovascular Disease Society for Public Health. This is our public book. This is for risk factor management, and these are all our photos of from campaigns. So from stadiums, from public health. These are all our activities. So we are trying to improve. We do our best. However, we have lots of still problems. In terms of stroke fellowship programs, we do have much more centers, much more accredited centers for interventional program. We do have much more centers. We are requiring much more centers for sure. And there are regional problems. Some of the regions still lack of stroke units and comprehensive stroke centers. We do have lots of collaborations, and we will be very happy to collaborate with Pakistani Stroke Society for future activities, for databases, and for future projects for both stroke care and for research. And it's my honor to present the current activities of Turkish Cerebrovascular Disease Society. Thanks for inviting me.
Thank you, Dr. Attila. Do we have any questions? Dr. Wasif?
Well, trying to, yeah. Ozdemir, thank you very much. I think it was a very informative talk, and Turkish Stroke Society is probably one of the biggest stroke society across all OIC countries. So I think there is a possible very strong future leadership role for the Turkish society to train or educate the rest of the OIC countries. So how you think that, how you could lead that effort, especially targeting our African countries who are low income and with different languages. So how you think, how we can help them?
Thank you. An excellent question, as usual. What we should do, we have still having some economical difficulties in our region. Thanks for your comments, but we do have lots of problems, but we are happy to help. The most important to create fellowship programs, legal fellowship programs. It can be under Menacino organization or other organizations, but Menacino is working on that. Osama and our colleagues all working on that. If we establish a legal fellowship programs in the region, from also for other countries, and get some reimbursement from companies and other supports or from the other societies, our societies. And these legal programs approved from Menacino organization or other organizations, we can accept fellows in the different parts of the region, Egypt, Pakistan, Turkey, and other regions, both for vascular stroke fellowship programs, or for also for interventional neurology or neurointerventional programs for all colleagues. So this is the way to go, to legalize or certify centers in all countries who are capable of giving education or giving training, and finding reimbursement, because we do have lots of economical problems in the region, giving opportunity to reimburse all candidate fellows and then train people. training is the major component of improving. So if we train more people, then we will improve. So all these people who will be trained, train other fellows in their country, then it will go like that. But we should work on it.
Thank you.
Thank you, Professor Vasai.
Thank you, Dr. Astamir. Are there any other questions? Okay. So with this, we come to an end of this session, and I think this was a very enlightening and informative session where we have very informative talks on stroke care in the region. I think the basic is that we need enthusiastic people who are really committed. If we want to improve stroke care in this region, we need to establish multidisciplinary teams and collaborate with one another to improve our systems of care, and so that we can help our people in the best possible way. And as Dr. Astamir also mentioned, that one of the best option is that we established or find ways for training our young neurologists and people who are interested in stroke care, so that we have better human resource, and not only the doctors but also the nurses and the allied health staff, and the rehabilitation people also. So with this, I thank you all for attending this session, and I especially the speakers who took their time out and give us a very comprehensive and detailed talks on the management of stroke patients in this region. And also I'm thankful to the Comstech Institute Islamabad and OIC for providing us this platform, and Dr. Mohammad Wasai for giving us this opportunity to attend this session and collaborate with one another. Thank you.
Thank you so much, Dr. Mamoona, for being the co-chair for this session and moderating the session. With that, I will conclude the session 2 for our conference. I would like to thank all the speakers present from various countries for giving us their time and sharing with us their experiences. So this conference is for 2 days. So just an announcement to all the participants that tomorrow we'll be starting sharp at 9 a.m. Pakistan Standard Time. We'll have 3 sessions tomorrow, so which will range from 9 and which will end around 4 p.m. Pakistan Standard Time. So thank you everyone for being here today, and that would be it for today. Thank you.